Good morning, everyone. Welcome to the NIH Toolbox Assessments Conference. I'm Molly Wagster, a program officer with the National Institute on Aging, and I'm going to be the master of ceremonies for this meeting. First of all, we're going to start out this morning with some opening remarks from leadership of some of the institutes that are involved with the NIH Blueprint for Neuroscience Research, which is supporting this conference and supported the development of two of the measurement systems that will be featured over the next 2 days. So it's my pleasure to start off by introducing Dr. Walter Koroshetz, Director of the National Institute of Neurological Disorders and Stroke, to give us some opening remarks. Dr. Koroshetz. Do we have Dr. Koroshetz on the line?
Hello, can you hear me okay?
Yes, we can hear you.
Very good, thank you. All right, well, I'm Dr. Walter Koroshetz. I'm the Director of the National Institute of Neurological Disorders and Stroke, and I'm here to welcome you all to this really important workshop and symposium. And I'm talking on behalf of the Blueprint for Neuroscience, which is a group of about 12 institutes and centers at NIH, all involved in neuroscience research. And it was started in 2004. But in 2012, the group decided that it was really important for all the institutes, for all their neuroscience research, to develop psychometrically sound tools to evaluate neuro and behavioral function. And that was the birth of the Toolbox. And the Toolbox has progressed since, and you'll hear the various uses of the Toolbox, the various expansions of the Toolbox into different populations. But the purpose right from the beginning, and which has stayed throughout, is to develop a set of brief, easy-to-administer tests of motor, cognition, sensory, and emotive function. Importantly, these tools are validated in large numbers of normal individuals so that when one does a study, one can see where your results fit on the spectrum of normal, of results of normal individuals, but also given the fact that these have been so widely used, one can see where your results compare to those of others who investigated different populations or even similar populations. So this is extremely valuable. One of the major problems in research is when you develop an intervention, for instance, and you look at a population versus a control group, you don't really understand the variance and whether your results are really within the normal variation or not. But the Toolbox is particularly relevant here because it's been validated in large numbers of individuals. So it's really what we think is kind of a common currency across NIH research and other research where one can have a North Star for the results in cognition, motor, sensory, and emotive function. And this has been taken up by over 14 current subscribers to the app. 900 publications have come out of Toolbox, and 460 trials in clinicaltrial.gov are currently listed as using the NIH Toolbox. Now, one application of these type of testing, particularly the cognitive testing, is in the detection of cognitive impairment. Cognition is not static, it changes over the lifespan. And so it's really important to understand what is the normal variation of cognition over the lifespan. This importance is emphasized even more now that there are advances in the treatment of dementia, particularly Alzheimer's disease. And so the Alzheimer's and the Alzheimer-related dementia summits that give us input to both the Aging Institute and NINDS on programs that are important to try to develop better treatments and management of dementia, brought out the need for testing to detect the earliest changes that might be related to these neurodegenerative conditions. This is pretty tricky, and requires the kind of effort that the toolbox has put in, but applied to these populations. And you'll hear about MyCog coming today, which was, in some sense, brought to the forefront by investigators who were involved in the toolbox and uses some of those same techniques. There are other groups that are working on a similar type of applications that can be used in the primary care setting to detect cognitive impairment in patients as they age. So I want to thank all the work that's been done by the Toolbox group over the decade, and I hope that we learned a lot today, particularly from the users of the Toolbox, so that we can always continuously work to make it a more effective resource for all of clinical neuroscience. So with that, thank you very much. I think I could hand it over now to Dr. Hodes.
Thank you, Walter. I'm Richard Hodes, Director of the National Institute on Aging. For the past 50 years, as we now celebrate our 50th anniversary, NIA has taken the lead in a broad spectrum of research, genetic, molecular, clinical, behavior, and social, about aging and life course. And in that context, as Walter has so well introduced, the Toolbox has been critical. I was with him, a part of the Neuroscience Blueprint, which in 2012 approved, finalized some of the work on the emerging, now continuing work on Toolbox, really one of the first products of Blueprint. And just as Walter has said, this serves an enormously important role in providing a common and comparable language for a multitude of studies that are examining endpoints in the behavioral and cognitive areas, allowing comparisons, leverages, and interoperability among them. An important advance now in progress is the development of the mobile toolbox. So as we move from paper and pencil to iPads and now to apps on phones, we're increasing then the ability of broader populations to participate and to help in generating the kinds of standards for evaluation of normal and abnormal behaviors that will allow us early diagnosis, early treatment, early interventions. So I share with Walter a warm welcome to all of you and expectation over these next couple of days that we'll learn more about your experience and that this will catalyze a still greater penetration and use of the Toolbox suite. Let me turn it back then over to, I think, Alison next.
That's right. Thank you, Dr. Koroshetz and Dr. Hodes. And now we have Alison Cernich, Deputy Director of the Eunice Shriver National Institute of Child Health and Human Development, who will tell us a little bit more about measurement in general, but also a bit about the baby toolbox. Alison.
All right. Thanks, Molly. And thanks, everybody, for coming here in person. It is really exciting to see people back in the conference rooms and talking and presenting posters, and I'm really looking forward to being here both this morning in person and later virtually. And I'm also excited to join Drs. Koroshetz and Hodes in welcoming you to the NIH Toolbox Assessments Conference. You know, I think this area of research as a neuropsychologist myself is incredibly exciting. I have been working in computerized neuropsychological assessment my entire career, and to watch these tools develop is really thrilling. I also want to say thanks to Dr. Molly Wagster from the National Institute of Aging, who first conceived of this conference, the NIH Blueprint for Neuroscience Research Program that provided funding for this event, and the NIH Toolbox Assessments Planning Committee, whose list of members is really too long to mention here, though I would truly be remiss not to mention Drs. Mankepke and Henkin, who lead NICHD's work in this effort. I also want to thank the Toolbox developers, who have been extraordinarily helpful in planning and will play an essential role in this two-day meeting. So NICHD's mission is to lead research and training to understand human development, improve reproductive health, enhance the lives of children and adolescents, and optimize abilities for all. And I'm grateful for the opportunity for NICHD to work with you all in developing new, innovative measurements, tools, technologies, and systems just like the NIH Toolbox. These tools can help support a wide variety of research studies and clinical trials for people of all ages and abilities. And honestly, from its inception, as mentioned by Drs. Hodes and Koroshetz, leadership recognized that in the blueprint the scientific value of shared measures across studies. And so we really understood both extramurally and intramurally the need for reliable, performance-based measurement for consistent domains such as cognitive, emotional, and sensory functions across the lifespan. So funding the NIH Toolbox, which includes assessments for ages 3 to 85, was one of the blueprint's first initiatives to address this. Early on in this process, we at NIH and you in the scientific community realized we need to incorporate assessments that are appropriate for the youngest children. And the Toolbox team developed the NIH Infant and Toddler Toolbox, or NIH Baby Toolbox, as an extension of the NIH Toolbox to fill this gap. And as someone who has done developmental assessments in the preschool setting before, I realize how complex this is. The NIH Baby Toolbox is a brief, standardized tool that includes neuropsychological, cognitive, and social assessments for use with infants and toddlers ages 1 to 42 months. And the developers engaged with the community to determine their needs and iteratively design the tool in a rigorous development process. Assessment components for each targeted age group were tested to demonstrate the reliability and validity of each assessment component against gold standards. The process included conducting and publishing a national norming study to ensure the measures produced valid and reliable data. And the study data from this norming study will be deposited in a repository that will be shared with researchers to conduct secondary analysis. Independent investigators using Toolbox data can share their data with the same repository, further aiding collaboration. And while the Baby Toolbox was a vital thing, it was also really designed to be easy to administer, eliminating the need for test administrators to have advanced degrees and optimized for use with mobile technology, making the Toolbox more accessible and easily administered in a variety of settings, including participants' homes and other non-clinical settings. And for any of you who have ever tried to administer a screening in a preschool and or in a pediatrician's office, you will recognize how valuable that is. And so really, I think the other piece of this that is really exciting is that we have these performance-based measures with computer-assisted and semi-automated scoring to facilitate unbiased assessments, and this is particularly helpful for assessment of pre-verbal and nonverbal participants. And we're trying to also cut down with these measures on participant burden and survey fatigue. We want to be respectful of people's time. And so this can be used in a limited time frame, so 30 minutes for a 1-month-old or 75 minutes for 42-month-olds. And we're hopeful that this time-saving instrument can be used in large-scale studies such as the Healthy Brain and Child Development Study because of this increased efficiency. I'm excited about the potential for Baby Toolbox and NIH Toolbox as a whole. These tools provide the opportunity for common data points across many studies, helping facilitate the ability to aggregate data and compare them, increasing the power of research we conduct. Not only that, using developmentally appropriate assessments can kind of help us take it to the streets, as it were. We can do real-time data capture that can help us do things like detect and intervene earlier for developmental delays and learning disabilities, track development over time, and understand the complexities of multiple modalities with greater clarity and nuance than ever before, all while linking these data into electronic health records in a streamlined, efficient manner and maintaining participant privacy and confidentiality. So I have looked at the agenda today, and while I won't be able to be here all day in person, I'm really excited to watch some of these sessions later, and I'm really excited about the amazing beginning you all have made as a community and get excited about the use of these tools that have laid the foundation for the science in this area. So thank you so much for what you've done and what you will continue to do from here. Really appreciate your work. Thank you.
Thank you. All right. We're a little ahead of schedule. That's always a good thing in my book. So I appreciate the leadership of NINDS, NIA, and NICHD to help open the conference. Some very important words and words of, that we appreciate in terms of how important these measures are and the time and effort that it takes to going into the development of them and to ensure psychometrically sound, valid measures that can be used in a variety of settings. So we're now going to move to the keynote addresses. I'm going to be introducing the first speaker, the first talk on the NIH Toolbox. And just to give you a little bit of background, back in the early 2000s, NIA, NIMH, and NINDS undertook a resource-building effort that we dubbed the Cognitive and Emotional Health Project, or the Healthy Brain. The overall goal of the project was to assess the state of longitudinal and epidemiological research on demographic, social, and biologic determinants of cognitive and emotional health in adults, and the pathways by which cognitive and emotional health might reciprocally influence each other. And one of the activities that was associated with the project was to conduct a critical evaluation study of the extant literature in this area. A blue ribbon panel was appointed, and in 2005, that panel delivered their report to the 3 institutes, followed by a publication of their findings in the journal Alzheimer's and Dementia in 2006. In their report, they posed several suggestions, one of which was the clear need for development of a standard questionnaire to measure cognitive and emotional health. In their literature review, they found that it was clear that little uniformity currently existed in measures used to capture results. This hinders not only the ability to share and integrate, but also to interpret results, as I'm sure all of you know. So at the encouragement of the 3 institute directors, staff from NIA, NINDS, and NIMH took the concept for developing a psychometrically sound tool for assessing neurological and behavioral function to the then fledgling NIH Blueprint for Neuroscience Research. The support for this concept was unanimous among the institute and center directors, and in late 2006, a contract was issued for the development of what is now known as the NIH Toolbox. The goals of the toolbox were clear: to maximize the yield from our research investment. Brief, valid, readily available measures were needed to encourage richer data collection and advance our knowledge of brain health and normal function. And at the same time, we wanted to avoid the pitfall of what many people going before had done, which was resort to the use of diagnostic tools and screeners, measures for disorder and disease, to assess healthy behavioral performance. So we wanted to provide individuals with a means which they no longer needed to resort to those types of measures. 12 years after the rollout of the NIH Toolbox, we've been graced with a psychometrically sound set of measures for cognitive, emotional, motor, and sensory function that not only have stood the test of time, but have evolved over time to keep the measurement system dynamic and able to meet the changing demands of assessment while providing continuity of assessment and comparison of data. So with us today to describe the development and features of the NIH Toolbox is Dr. Richard Gershon, Vice Chair of Research and Professor in the Department of Medical Social Sciences and Professor in Preventive Medicine, Health, and Biomedical Informatics at the Northwestern University Feinberg School of Medicine. He served as the principal investigator for the contract to develop the NIH Toolbox. Dr. Gershon.
Thank you so much, Molly. Whoops. It's really a pleasure being here. I'll get started. I have lots of thank yous towards the end, and there'll be other places to thank people. So as Molly indicated earlier, the 15 institutes and centers, offices of the NIH that support neuroscience research form this coalition, the Blueprint for Neuroscience Research, and a contract was awarded to Northwestern. We got together with 250 of our friends from around the world, actually, and 80 academic institutions, really to be a worldwide effort to determine what we wanted to have, and we put the best people from around the world developing the individual measures. And we released originally in 2012 at a meeting similar to this at the Neuroscience Center. And then close to 10 years later, we released version 3 of the Toolbox, which was fully updated and fully renormed. We'll talk about that in a few minutes. So originally, when the Blueprint got together, I think the original goal was to have put something together that had cognition and emotion, that we shouldn't be assessing cognitive functioning without emotion. And there's always two meanings of the word depression. Obviously, there's the how depression is an emotional construct, but also depression depresses cognitive functioning. So putting these together, and then motor and sensation were also added. And we wanted to use existing measures wherever possible. That ended up being a little bit more of a challenge than we thought. We wanted things to be familiar to the research community, and we really wanted to avoid duplication of effort. We would develop novel measures where needed, and we would employ modern psychometric approaches and methods. So the first thing we did, I think Walter actually went through there, we did an expert survey of selection criteria, and just what did people want? How long did people want to test? What were the characteristics of the measurement? And then we actually had focus group interviews with patients, expert interviews with people who would use the system. We did surveys, I think 200 people to nominate and rank subdomains and constructs and determine instrument costs, time constraints. How much would people be willing to pay, and how long would they take to do it? I'll be talking a little bit tomorrow that I actually think time constraints are probably the number one guidance for how you develop and pick a measure. We had a consensus meeting in month 10. We conducted extensive literature review and actually developed a library of close to 1,400 potential instruments to include in the toolbox. We broke into a lot of working teams. We had 9 domain teams you can see on the screen, and we had other working teams in EPI, tech, Spanish language, multicultural, pediatric, geriatric, scoring, accessibility. These people were all involved, and all the teams cross-met to make certain that we're covering across ages 3 to 85 was quite the range. Which brings us to today, where the Toolbox is in use at over 1,100 institutions on 3,000 iPads, 40 different countries. And V3, we changed how this works. So it's, well, a lot hasn't changed, but as an update for those of you who haven't used the Toolbox, with an annual license, it's useful for unlimited administrations. The 50 tests that make up the NIH Toolbox are there. Most tests are under 7 minutes. Actually, many of the tests now are under 40 seconds. We can get clinical reliability in certain areas in 40 seconds. It's offline. We renormed it for ages 3 to 85. We'll talk about that now, and there's some sessions later today. Flexible test administration now, and everything's automatically scored by the time it's over. I'd really like to spend 2 hours on this slide, and I'm going to spend 30 seconds or a minute. But the NIH Toolbox really covers 4 different areas. Cognition, which is clearly the most widely used battery that we have, followed by emotion, which has a series of measures which people use for various studies. We really have a very rich motor battery. It's used nowhere near as much, but we spent a lot of time trying to come up with very, very brief measures of motor functioning, as well as sensation. And then all these domains were created for 3 to 85. They have tests across that age range, and we originally normed all these measures. Let me spend a little time on the cognition domain test. So everything we did, we decided, it's really a tradition in neuropsych assessment to update and renorm tests every 10 years. So over the last last 3 or 4 years, we updated the tests and then went through a very large norming exercise. So as a refresher, the NIH Toolbox is only available for use on the iPad. When I first saw an iPad, I thought, oh my goodness, if I had to structure and write down what features we would want in a hardware device for testing, the iPad was it. It's a solid device. It's machined out of a single piece of aluminum. It's strong. It continues to get, it has neuropsych caliber timers in it. And we're going to hear for the Baby Toolbox later. It has new features that we're able to take advantage of. But all of our tests are only here. We've been asked to port it to other platforms. I'll explain a little bit later why not. So we updated the oral symbol digit test. Dimensional change card sort test. Again, a participant's asked to match a series of pictures and pairs to a target. This range goes for ages 4+. Now, by the way, for the most part, V3, even more so than V2, we're using almost the exact same tests for 3-year-olds as we're using for now. We've demonstrated these measures for use up to age 95. It allows for very easy comparisons of scores, and you can watch developmental trajectories. In some cases, we brought the older versions of the test down to kids, and in other cases, we literally took the 3-year-old version, and now 75-year-olds are using it, and so are 25-year-olds. The tests aren't necessarily the same length, and the tests do start at different starting points depending on age and ability. Flanker inhibitory control and attention test. This is a test where we actually took the younger kids' version and brought it up. Rather than just have arrows, we added fish. It's a very standard test of flanker functioning. This is a test which actually improved. All of our time tests really improved in V3 because the sensitivity of the timer in the iPad is greater than the original hardware that we did this on. So we're able to get the equivalent of testing where people actually were faster than some of us, had timers there, right? And you could press a button and you get this very fancy level timing. The iPad's doing that automatically, so it knows exactly how much time was taken and it records it with each item. The asserting working memory test, another test revised for use in V3. We learned over time, we thought we had whole teams that concentrated on diversity and on cultural equity, and nobody seemed to catch 12 years ago that a blueberry is an unknown fruit outside of the United States. No one knows what size it is. Similarly, a pumpkin in the United States is this big, but if you go to Europe, a pumpkin is this big. Those are types of things we've removed from the toolbox in order to make it more applicable worldwide. Picture sequence memory test happens to continue to be one of our tests that's highly sensitive to assessing cognitive improvement and also cognitive decline. Pattern comparison processing speed test, with the increase in improvement in this sensitivity of the timer, we've actually lowered the floor and raised the ceiling on these tests. And our oral reading recognition test continues to be, it's a computer adaptive test. I might actually have time, given our extra time here, that zeroes in on a person's reading ability level in just a couple of minutes. And the picture vocabulary test, which is still our second crystallized intelligence test. We actually lowered, it says age 3+ here, but we actually padded words at the lower end so we could actually use it for the baby toolbox as well, so we extended the range. People will be talking about later, we've added change sensitive scores. Continues to be a highly sensitive test of crystallizability. And the Ray auditory verbal learning test, we didn't used to have a delay version. This was a supplemental test in the version 3. So it's now been updated, so you can give the original test, and you can also use the delay version, which many people use in clinical studies. Speeded matching is a new test. Dr. Aaron Cott is here talking about later, and developed by grants outside of the NIH Toolbox over the last few years. We added it here as a test, executive functioning test that's much more applicable in the 3 to 6-year-old range. And visual reasoning test, a test kind of at the opposite end of the spectrum in terms of its ages 4 and up, but there was a call for visual reasoning in several studies, and we added it in. This looks so nice and easy here, but it actually is one of our more difficult tests and does probably will do ultimately a good job of assessing giftedness even through 8th grade. Face name associated memory test. Dorene, Rentz, and team have used the face name test to really as a digital biomarker to be able to assess amyloid buildup, and this test is available on numerous platforms, and Dorene's team helped us develop the face name test here, and we've now added to the toolbox to increase assessment at the upper end of the scale. I should put out in the original development of the NIH Toolbox, we only included measures that would have applicability from ages 3 to 85, which of course left some shall we say, we're a little light at the very youngest ages because we needed tests that we need in adulthood. And at the upper end of the age scale, we also were light because those constructs weren't available, weren't needed younger. So in the version 3 of the toolbox, we've actually added measures at both ends of the spectrum. I could spend one slide on each of these areas, but this is the emotion domain framework for the NIH Toolbox. Under V3, we released all of these tests as 4-item computer adaptive tests, which gives us clinical reliability for, actually in the clinical range of interest for all of these tests in 4 items, which is 35-40 seconds using computer adaptive testing. And so there are separate tests for all of these. These tests, by the way, are separately available at any REDCap installation, and all 6,000 REDCap installations around the world. Motor domain tests, we developed 9-hole pegboard test, grip strength test. Actually, that JMAR grip strength dynamometer switched to our norms after we came out with it because they realized our norms were better than theirs. Standing balance test remains one of the tests that I think is technologically one of the neatest things we've done. It uses we designed it for use with an iPod, which you can no longer buy, but so we were fortunately able to move it to an iPhone, and we can develop a highly precise measures of balance, 6-7 minutes, and then the 2-minute walk test, which actually was just, developed by people who use the 6-minute walk test, but in the effort to decrease burden, we renormed the 2-minute walk test with correlation in the mid-90s to that, and the 4-meter walk gait speed test as well. And the sensation domain, word and noise test, and actually after many years, we were finally come up and validated a new pure tone audiometry test, so you can include that test in a bank. We still have olfaction odor identification test, which became incredibly popular early in COVID when it was thought that the only way we'd get people back to work was to determine whether or not people regained their sense of smell or whether they had lost it, their sense of smell as a potential way of detecting COVID. It's the same test that the people on this development team are the same people who developed the $30 and $40 tests that many people use in their studies. They developed this. I think the cards are about $2, $2.50 in for most studies. I know I had a call early in COVID. Richard, what would the quantity be for 3 million? And I said, okay, that may take me a little while to figure out. But fortunately, that's not where we had to go. And a visual acuity, we've currently had a distance acuity test, and we've also then recently added or are in the process of adding a near vision test. Turns out a lot of people have the wrong glasses prescription. So we're sitting there measuring their cognitive ability, but the truth of the matter is they can't focus on the screen that's right in front of them. And then the other 2 sensation domain tests are a pain intensity survey as well as a pain interference survey. V3 is going to have a growing number of composite scores, but initially similar to the past, we have an age 7+ composite for a total cognition composite, a crystallized composite, and a fluid composite. These composite scores correlate very highly with the version 2 tests. As I said, some of the underlying tests we improved. Fortunately or unfortunately, when you approve a test, it doesn't necessarily correlate as well with the old test. So some of the underlying tests, by lowering the floor, raising the ceiling, actually don't correlate as well with the old one. It's a better test, but thank goodness the composite's still there. And then we have the age 4 to 6 composite that's made up of a shorter battery. In the translations department, and I'm only smiling because our translations brochure apparently didn't show up, we currently have for version 3 Spanish, Fertile Crescent, Arabic, Hebrew, French, and Italian. I say Fertile Crescent Arabic because in version 2 we have a Saudi Arabian and Egyptian version of Arabic, Spanish as well as, I'm not even going to try to pronounce some of these, French and Italian. And we are aware that people, and I think a later speaker will talk about, that people are using the toolbox with the sound turned off in studies around the world, and we're trying to add language versions. For the most part, really indebted to the pharmaceutical industry that would like to use the toolbox in places and are actually currently speccing out what it costs actually to norm the toolbox throughout Europe so they can have normative values. So V3 norming and validation, close to 4,000 individuals. This took place just a year and a half ago, I guess. 2,300 kids, 1,700 adults, fully census balanced by census region, race, gender, education level. And then what we decided is, while there have been literally hundreds of clinical validation studies conducted with the NIH Toolbox, we thought in order to bring V3 out, we should immediately conduct some studies so we don't wait for the community to do that. So we did those in ADHD, ASD, learning disabilities, in reading, and as well as concussion. And then we also ran concurrent validation studies comparing V2 to V3, the WAIS, the WICS, the WIPC, the CVLT, the WMS, so that it would come out fully usable and ready for use. In the publications department, 350 plus validation studies. I was asked to speak about 6-7 years ago. Somebody said, could you come and speak about the clinical uses, clinical validations of the toolbox? I said, sure. And then I turned to a student and said, hey, do we have any? Turns out at the time we had 250 studies. We just don't know. You know, we're developing the measures. We use them somewhat for small studies internally. But it turns out the world has gone out. And different subpopulations get that to a minute. As Dr. Koroshetz pointed, we're in a lot of current clinical trials. I think the 570 plus peer-reviewed journal articles about half of what's actually out there and available. Validation studies in the literature, I just think this is amazing. These are not ours. I have another slide on neurological disorders, but psychological disorders. A lot of studies in adult and pediatric cancer, people using the NIH Toolbox to track that a drug does not. A child recovering from cancer is brought in annually to see has their cognitive functioning been impacted. Cardiovascular disease, autoimmune, I don't need to read these. It's across the gamut of scientific areas. In the neuro area, amnestic mild cognitive impairment, early stage Alzheimer's disease, stroke, TBI, spinal cord injury, Parkinson's disease, all over. I've been counting, I almost brought, there was another article published this morning. We're running an article being published, 3 or 4 articles a week at this point of studies that are using the NIH Toolbox. Developed during COVID, and I put limited release because we're not quite sure how widely we want to support this, but we needed something that would maintain the reliability and validity of the toolbox during COVID. And for the environmental child health outcomes echo study, the sites, we created a version of the toolbox where you can actually see the participant. We get an iPad to the participant, and you can talk through the app. We tried Zoom early on. Zoom, there are delays, we lost time. So instead, we send out an iPad to a subject. They can see the test administrator can see them. We lose none of the reliability, and the results are communicated back in real time to the test administrator's iPad, so there's no new data flow or things like that. NIHtoolbox.org has been our website for a long time, but we have a completely new website, and thanks to several people in the room for putting that together. Let's see if I go backwards a second here. You can see this is really the address to learn about all the testing systems, although the NIH Toolbox is the one that's most deeply embedded here, where the research is, training, et cetera, how to get the app, and descriptions of all the measures. So there's curated content, our composite scores, et cetera. You can find publications, although we're trying to list all of them. They're coming out so fast. Google is still a good resource. We've always had free access to all our administration manuals, technical manuals, all the white papers, all the training videos, e-learning, et cetera. All the FAQs. We added an artificial intelligence-based chatbot, so you can send in a question if you can't find the answer, and we'll tell you what the answer likely is. And what I hear a couple hundred times in the last few months, the answer was there. You didn't have to wait for someone to get back to you, and if not, we have people that will send you an email back. I'd like to thank the original NIH project officer team. Several people have come back in the room. Some of these people have moved on to other institutes or gone other places, but it's a very large team from the NIH that participated in the original NIH Toolbox. Many of these people still check in on a regular basis. Current scientific review board. In the interest of time, I won't read all the names. You can see some familiar faces up there, but people who are keeping us honest and checking up on what we're doing. And the V3 development team, and I realized, so the original team was 250 some odd people. I think we're rolling names and thank yous to everybody on all the measurement systems over the lunch hour. You won't eat lunch if you stay and watch every single name scroll by. But these efforts take a lot of people, and my personal thanks to everybody who's done this. This is not a Richard Gershon effort. It's a lot of people effort. And thank you very much.
Good morning. My name is Rebecca Hommer, and I'm a program director in the Division of Clinical Research at NINDS. And I'm so happy to be here today to introduce Dr. Mike Wolf, who will be speaking to you about the development and features of the MyCog program of the NIH Toolbox. So before turning the stage over to Mike, I will start with a bit of context. So the early detection of cognitive impairment and dementia has long been seen as a healthcare priority in the United States. Detecting cognitive impairment is a required component of the Medicare annual wellness visit, and a number of assessment tools are already readily available. However, despite the availability of tools, cognitive impairment and dementia remain under-recognized and underdiagnosed. The reasons for this are multifactorial, but one barrier has been the ability to affordably, quickly, and seamlessly integrate the cognitive assessment in the primary healthcare workflow and the electronic medical record. In 2017, in direct response to Alzheimer's disease-related dementia milestones in the National Plan to address Alzheimer's disease for multiple etiology dementias and health disparities, NIH issued a funding opportunity calling for the creation of a research consortium to establish, test, and validate paradigms for detecting cognitive impairment and dementia, including dementia, when a patient, relative, or care provider indicates concern in a primary care setting and other everyday forms of clinical practice. The development and validation of MyCog was one of 3 awards funded as part of the Detect PsyD consortium, and I'm so excited to be able to say that now it is in its 2nd cycle of funding and being evaluated as part of a pragmatic clinical trial to test its effectiveness in detecting cognitive impairment and dementia in patients who are part of a network of primary care clinics that serve patients of diverse backgrounds. And now I'll turn it over to Dr. Wolf, who is the Associate Vice Chair for Research in Northwestern's Department of Medicine and the Director of the Institute for Public Health and Medicine, the Center for Applied Health Research on Aging. Mike will tell you more about MyCog and how we got to where we are today. Thank you.
Good morning. So as I mentioned, as Dr. Hommer said, I'll be presenting about MyCog, a clinical application of the NIH Toolbox that we've been working on since 2017. So first I was just going to talk about the MyCog story and its development and how we are responding to a public health priority, as Rebecca alluded to. And just thinking about the Alzheimer's disease-related dementia summit that NINDS has put on for quite some time, you know, the work that was being cited is really, in what MyCog is one of the 3 awards that we're trying to tackle in addressing this public health priority, is really related to recommendation priority 1 for the multiple etiologies dementia subcommittee, which was really focused on evaluating pragmatic approaches to objectively detecting cognitive impairment and linking it to quality of care. That was a part that's very much underscored here, is the linkage to quality of care. But when a patient, a care partner, or a clinician reports cognitive, behavioral, or functional changes, this is a top priority that has been issued since 2016 and continues to in the most recent version of the summit in 2022. And that led to the consortium that Rebecca and Rod Corvo at NINDS have led and that we've been fortunate to be a part of since, again, 2017 when it got kicked off. And Detect PsyD, or the Consortium for Detecting Cognitive Impairment, including Dementia, has really been a partnership with ourselves and our colleagues across the U.S. in terms of specifically Einstein and UCSF. So I want to make sure to highlight the great work that they're all doing as well. The justification for the consortium really is that, 1, we need to focus on really mobilizing primary care settings because they are well positioned to detect cognitive decline. Again, these are also practices that are incredibly busy, that have lots of targets on their back in terms of what else can we be doing to capture not just cognitive decline but other factors, since they are on the front lines. And the focus has also been justified that there's, despite the opportunities of the annual wellness visit, where we do have the opportunity to have patients coming in and where there is a cognitive assessment since 2011 that's required to be included in that visit, what we do know is around 40 to 76% of primary care physicians fail to recognize cognitive decline. Over 90% of mild cognitive impairment cases are missed during these visits. And the root causes, as you would expect, are many, including, more importantly, resource and time constraints that we hear quite a bit about. as well as lack of training and awareness on how to detect cognitive impairment, and also the limitations of existing cognitive assessments in the presence of comorbidities and how that plays into it. I will say during the past several years working on this project, we've talked to so many primary care physicians, and the one thing I thought was really interesting was MyCog, as many other short tests, are kind of commonly used in the practice. And the one thing we heard from many physicians is, as patients leave annual wellness visits, what they find them doing in the waiting area is whispering the recall words to the patients waiting to go in for their annual wellness visit. So the notion of cheating on the cognitive assessment was a little bit new to me during this process. But there is a need for brief, electronic health record, tethered, easily administratable and interpretable tools with clear turnkey recommendations. Again, that's that link to quality care that are really important for ensuring follow-up and care management. From our colleague Kate Pacine at UCSF and her team, Elena Soy, put out this great paper that also just highlights that there's a major emphasis when we talk about early detection that we don't further drive health inequities. There's lots of interest from the Medicare data in California that they dug up and found that Asian, Black, and Latino adults are less likely to receive a timely dementia diagnosis, as also Asian adults in particular, are also unlikely to receive fewer diagnostic evaluation elements. So this idea that, when we think about the consortium and the work that we're doing, that we want to be focusing on health disparate populations is really kind of key as well. So again, since 2017, Detect CID, has included the 3 programs that I mentioned here at the below, including Northwestern's, with the overall goal to increase the frequency and improve the quality of patient evaluations for detecting cognitive impairment and dementias in primary care and other everyday clinical settings. So thinking about ambulatory care in general, wherever we could be possibly administering these tools that could be better identifying patients at an earlier stage of disease would be important. And again, addressing barriers to detecting impairment is also important. So fidelity, not just effectiveness of these tools, is really, really highlighted. So I'll highlight just again some of the issues right now in terms of the 3 sites that are going on. I did want to acknowledge Einstein and UCSF for their great work as well. For Northwestern, we have leveraged the Toolbox, excitingly, for 2 specific assessments, the picture sequence memory and dimensional change card sort. Were both kind of considered, and I'll talk about a moment about the fact that it's been shifted to self-administration. And the interesting thing about Detect CID that I think is exciting is that there is cross-consortium data harmonization of outcome measures, so we can be looking across the different platforms of our tools. So not just looking about MyCog, but also how other tools and when and what circumstances might one paradigm be more efficient than another. So again, these are the 2 tests that we've been using, a measure of executive function and episodic memory kind of imparted, mostly because these are 2 tests that were thought to have the best opportunity to have clinical utility for detecting cognitive impairment and dementia, and especially, again, factoring in a target specifically around MCI. And then thinking about some of the features and how we actually had to go about thinking about, okay, if we have an opportunity to think about new tests, there are already many, many short abbreviated screeners that are out there, so why another test? So a lot of the work in the consortium early on was really thinking about, and what we were doing with MyCog is spending a lot of time, iterative design, thinking about what could be better, how could things work efficiently, especially if we're incorporating tests that might take a little bit more than something as brief as a MyCog assessment. So this was a user-centered iterative design approach involving clinicians, administrators, and patients familiar and working in primary care settings that are diverse. So not just at our own academic practices, but working with federally qualified health center networks throughout the greater Chicago area and elsewhere. As it is iPad-based, I think the other thing we were trying to factor in is many of the practices that we were working in, especially federally qualified health centers, don't have iPads naturally embedded in their workflows. So thinking about what this means to add a new technology into the mix and how that could actually streamline their practices and be a benefit, I think is important. A lot of our physicians through in the Chicago area, we've been talking with for the past decade about how do you, the opportunities that are there for an iPad, not just for maybe a cognitive assessment, but thinking about medication reconciliation and other tools. So there was a lot of interest in actually finding ways to embed the technology into their practice, again, with certain caveats. we heard a lot over and over again about how this could be, including MyCog and an iPad, could be of great value and utility if it could be self-administered. So, I think I'll definitely give a lot of shout out to Richard for really pushing us to kind of think about this as something that if it's not going to work as a interviewer administered or a proctored assessment, and it needs to be self-administered, that we do need to take the time to make that pivot, which we did. It was meant to be, again, defined to avoid manual data collection from an assessment, and even if it is a few extra minutes longer than what would be currently in practice with the current standard of care, the idea that we could actually save some time by actually tethering it to the electronic health record. That means the iPad has to now communicate with the electronic health record. How to actually do that, we spent a great amount of time, and a lot of the Northwestern team who are here, and I'm hoping you'll be able to get a chance to meet with them later as they give you a deeper dive into MyCog, can share the incredibly difficult and challenging work to make that happen, and successfully as it has been. The way it works right now with MyCog is it communicates to the EHR through a bar or QR code, and that allows the iPad and the assessment, which cannot maintain any private information or data after the assessment is performed, can share and identify and drop off the information exactly where it needs to for the patient. It auto-populates results with a red light, green light strategy, so it's yes or no, high likelihood of cognitive impairment. So it should be a very simple and easy approach that I think the NIH has really drawn us to make sure that this is something that can clinically be determined very efficiently. And again, we also don't want to provide just the test result without also offering clinic-tailored turnkey recommendations in an Epic Smart Set or a best practice alert that can link to a list of all of the guidance, in terms of what's next. So you do have identified a high likelihood of cognitive impairment, thinking about everything from, how do you rule out reversible causes, thinking about any particular tests or labs or imaging that you might want to do as a result. What other types of referrals would you make beyond neuropsych or behavioral neurology? In terms of, for us, we've been doing a lot of work with care coordination at our healthcare system. And I think, again, another thing that Richard highlighted from the very beginning when we sought off this opportunity to work with MyCog into this kind of space was to think about the value of this over current cognitive screeners and being able to look at not just normative decline, but also relative decline by getting a patient's actual baseline dropped in. And there are features already that are basically endemic to a lot of electronic health records that are like flow sheets, just like lab values. You can start to track performance, especially with annual wellness visits. You'll be able to start to see, even if patients may be starting at a little bit of a higher place, maybe higher educated, that if they're actually feeling or even self-reporting a concern, you might be able to track that because you'll see the drop, even if their performance still falls within the normative range of the tests. Here are some snapshots from our own electronic health record of what these tests would look like. Talking to clinicians, we wanted to make sure we shared with whatever values they thought would be important. So it wasn't just giving them a red light, green light. We did provide test scores for the overall score and also for each individual score. And we give a threshold as well. So the idea is that a lot of clinicians will say, well, I would want to know if they're on the threshold, maybe they're just having a bad day, and maybe I'll think twice before sending them down to a neuropsych evaluation, and maybe recheck to have them come back within a period of time to reevaluate, versus someone who is well over the threshold and they feel they have good confidence that the performance is indicative of an impairment and that they need to triage that patient differently. So those values are in there at the moment. This is our paradigm that we've launched right now, and as Rebecca highlighted, we have a clinical trial, a pragmatic trial underway that's really evaluating this in practice to see how this actually works. And there's really two ways you can imagine how you would deploy MyCog. And one is just obviously through an annual wellness visit, where we think that the cognitive test can be replaced out using MyCog, that there's lots of value at it. In terms of having an assessment in primary care that is highly specific, being attentive to the fact that there is a U.S. Preventive Services Task Force guidance that kind of is somewhat counterintuitive to the annual wellness visit requirement since 2011 to to actually do cognitive assessments, but there's a concern for psychological harm if we were to do universal screening. So at least we know with the annual wellness visit, patients are going to be potentially getting a cognitive assessment. So we do suggest that we would put MyCog into that mix. And then for a routine visit also, and again, as highlighted by the ADRD Summit recommendations, anytime a clinician suspects an impairment, the patient is reporting it or a care partner, that would also be a way to mobilize MyCog. And so that does mean, from an electronic health records standpoint, and one of the things we've learned is the nature of the visit, if the visit's coded as an annual wellness visit, versus how do you actually ensure that it can be coded at any time, that the tool for MyCog can be deployed at any time that a clinician would like to, not just with an annual wellness visit. So again, in thinking about our ongoing studies with MyCog, we do have 2 pragmatic trials that have been going on, one from NIA and one from NINDS. The first trial was really focused on academic practices with replication sites, and that has 40 practices in place right now. And then our MyCog trial, or what we call Detect CID version 2, is focusing primarily on federally qualified health centers that are serving Latino and Black communities experiencing health disparities in ADRD. And so that is, again, focusing on where what we have been able to do is we built this platform first in the Epic Electronic Health Record, which is both an expensive product for a healthcare system, but also one of the more widely used platforms. And we actually wanted specifically with the NINDS trial, with the Detect CID, to show that lightning can strike twice, that we can actually do that. It's not agnostic to one electronic health record platform. So we actually deployed MyCog and have been spending quite a bit of time to make sure that it can work effectively and tailored to the platform itself by showing that it can go to Greenway and another group called Canopy, which is an electronic health record that it might be more used in a community health center setting. Our primary outcomes for both trials are rates of detected cognitive impairment, the proportion of those detected cases that are actually early detected cases, MCI, and also if we're actually can be in specifically for the pragmatic trial of a Detect CID2, we're looking to see if we can actually reduce disparities within our sites. Secondary outcomes also include referrals, rates of referrals, the rates of diagnoses actually hitting the electronic health record. So it's not just detected, but diagnosed. And also using machine learning, we'll be looking to see if, through natural language processing, if caregiver involvement has also been increased. Fidelity outcomes are equally as important in this case as a pragmatic trial. So we are looking at cost, workflow impact, and referral acceptance. I want to give a shout out specifically to a lot of great work here. Again, you'll be able to hear a lot more about this today and also tomorrow. About how, again, trying to meet the needs of the diverse healthcare practices that we are working with. An extension of MyCog has been made to MyCog Mobile to have a smartphone version in development that can also go unproctored, if possible, as another way to address getting cognitive assessments done before a visit. Right now, we see that in our own healthcare system, it started out with annual wellness visits where we do now increasingly want to push out anything that could be completed by the patient before a visit, because these annual wellness visits are packed in. So if we can do anything to reduce that burden, the better, but only about 20% of adults over 65 will go on to their patient portal and complete an assessment beforehand. So the idea that we could actually do things on a smartphone, rather, that would actually be helpful. But again, a lot of what we're trying to create is really a coordinated system of products around MyCog. So if you can actually get as many people that would be willing to complete an iPad, because that number of less than 20% just jumped up to about 42% with some health system initiatives that have been going on. So the more people that we can actually be doing assessments ahead of time, the better. If those results are populated and also have an opportunity for a clinician to even look at and know that this might be something that has to be discussed during the visit and targeted, that's all the better. But also having that iPad version still in play, so when patients do come in and they haven't completed it by phone or, for anything for that matter, any patient-reported assessment, that having the iPads in the practice can actually be a way to get at the patients in the other manner in a more effective means. So whether it be pre-visit or at visit, having to be able to do more work that you could also address multiple languages, another issue that we've been seeing more and more from our healthcare system partners, to make sure that MyCog can be available in all the language they need, and also considerations of other tests that might work better also, especially on the MyCog mobile version, that can increase the accuracy of the tests, are all things that we're working on right now. And thank you.
So hello again. This morning, it's my pleasure to introduce the next talk and next speaker. Unfortunately, Dr. Melissa Trevino, who was supposed to introduce the next talk, wasn't able to be with us this morning, so I have the honors. So it's my pleasure to introduce the Mobile Toolbox and our speaker, Dr. Dorene Rentz. The National Institute on Aging recognized the need for a research infrastructure to be able to monitor cognitive abilities via mobile devices. Mobile device administration has many advantages in terms of accessibility, efficiency, and affordability, and more people can be tested more quickly. Furthermore, use of mobile phone technology to assess cognition could allow examination of the influence of transient, sort of psychological, somatic, or contextual states, such as, being in a social environment with friends, on cognitive performance in a real-world environment. In 2017, the National Institute on Aging issued an RFA that we titled Mobile Monitoring of Cognitive Change, and in 2018 began funding the development of the Mobile Toolbox to create a library of cognitive tests and supplemental scales that are open source, validated, and normed, and that can be administered on mobile devices. It didn't take us very long to appreciate the urgent need for self-administered measures. During the COVID-19 pandemic, we were all able to witness firsthand how important it is to have measures on hand that are psychometrically sound, can be administered remotely, and for which the integrity of the measures can be maintained. Dr. Dorene Rentz is professor of neurology at Harvard Medical School with dual appointments in the departments of neurology at Brigham and Women's Hospital and Mass General Hospital. She's been an essential figure in the development of the Mobile Toolbox and is joining us today to speak about the development and features of this measurement system. Dr. Rentz.
Thank you, Molly. Good morning, everybody. This really has been a dream of mine to have remote assessments for probably the last 10 years, so I'm thrilled to be able to talk to you a little bit about the development and features of the Mobile Toolbox. As you know, this is a multi-site effort across the MTB 1 and 2, and many different academic institutions are participating, including our own. So the Mobile Toolbox, like the NIH Toolbox, is a suite of mobile cognitive tests that was recently developed and validated against gold standard in-clinic tests. You're going to hear more about that in session 2. The Mobile Toolbox is administered via smartphone on an individual's own device. It's in iOS and also in Android. The data is encrypted and uploaded to a secure electronic data capture system. And it was initially in Sage and is now in REDCap, which is more familiar to a lot of academic institutions, and instantly available to the researcher when they want to examine the results. That also is going to be talked more extensively in session 2. And the important thing is that a Spanish version is going to be available later this year. So how does it work? The participants get an automated email with a link to download MyCap, or they can use a QR code that's provided in the email. They can also choose to download MyCap from the App Store on an iOS or Android phone. The link is participant-specific with a unique ID. Once downloaded, they click a button to join the Mobile Toolbox study and begin their assessments. Once they complete the test, they can't go back, they can't do it again, they can't practice for the next time, so that it's a one-time capture of their cognitive performance. The test scores are automatically transferred and instantly available. So what does it consist of? Like the NIH Toolbox, it has 8 mobile toolbox core measures. It takes its norm from ages 18 to 85. It takes approximately 30 minutes to administer all of the tests. There are 6 measures of fluid cognition. They measure episodic and associative memory. I'm going to show you the tests in detail in a little bit. They also measure executive functions of inhibitory control, attention, and cognitive flexibility. They also measure working memory and processing speed. And then there are 2 measures of crystallized cognition. That is things that are well learned by the individual, and we'll talk a little bit about that as well. The slide also shows you how it appears on an iPhone, and I have to say, having done cognitive assessments for a long time, the images on the iPhone are beautiful. You know, so even older individuals will be able to see them quite clearly. Here's the first measure, arranging pictures. I think Richard had already talked about this, but what happens on the iPhone is that you hear a story, and the pictures are scattered, like you can see, across a black box. Your job is to put the pictures in order of the story. There are all practice sessions to every task, and then an indication that you've done it correctly. Then there's a test I helped develop, which is also a measure of episodic memory, called an associative memory task. It's called Faces and Names in the Mobile Toolbox. And here you initially have an encoding trial where you examine a picture, and in order to know whether you encoded it or not, you tap if it's easy, if you think it's going to be easy to remember that face, or harder to remember that face name pair. After this test, you'll get a whole series of other Mobile Toolbox tests, and then later on, you're going to have a delayed recall of faces and names. So similar to the NIH Toolbox, you have kind of a flanker test, which is arrow matching. Then you have the shape color sorting test, where again, you're told, look for the shape. And you have to match the shape of the dog to the dog, irrespective of the color that it's in. So it's something similar to like a Wisconsin card sort test. You also have sequences, which is kind of like a sequenced digit span test, where you're going to see numbers and letters shown one at a time. Your job is to remember the numbers and letters, but then in the next slide, you first tap the letters you just saw in alphabetical order, and then the numbers from smallest to largest. Not an easy task as it gets longer and longer. The other test, very similar to digit symbol coding, is the number match. And here, again, you look at the symbols and its corresponding number. And then you'll be shown a symbol, like you can see, and you put, in this case, the 1 under it. The other one gets a 2, the other one gets an 8. So again, it's kind of like a digit symbol test, measuring processing speed. Then you get the delayed recall of faces and names. There's probably about a 8 to 10 minute delay once you get all of those other measures done. And there are 3 phases of memory that it measures. There's facial recognition. Sorry, Emily doesn't appear on the facial recognition, but she is there. And then you get a delayed recall task where it's an immediate delayed recall, where you have to remember the name of the face and put the E under that name. And then there also is a name recognition phase. All of these tests I showed you so far give you an accuracy score as well as a time score. And a paper that is almost getting ready to go out for publication is retest reliability of faces and names. 123 individuals participated in this study over a 2-week interval. And there are practice effects if you do it for a second time in normals over the 2-week period. But the advantage of this is the fact that if it's not, if you don't notice that practice effect, then that's a red flag that somebody may be headed toward more impairment. Then you have the spelling test. You'll hear a word, and then you have to write the word next to it. It measures crystallized intelligence or spelling. And then finally, there's a word meaning test where you are presented with the word talk, and you find in the multiple choice the word that best is closest to the word that you're being asked to define. All of the tests have practice sessions as well as the actual test itself. There's an adaptive learning aspect to the mobile toolbox, because I got to tell you that vocabulary and that spelling test gets harder and harder, and it doesn't produce torture. It does stop at the right time so you don't get discouraged. So one of the things we've been doing at Mass General with my postdoc, Rose Dutton, is to look at the mobile toolbox in relationship to other paper and pencil tests. And one of the things that I'm interested in is seeing whether or not this mobile toolbox could be used in preventative trials for Alzheimer's disease. I want to try to bring it into the clinical trial environment, and I wanted then to develop what we use traditionally in clinical trials as a mobile toolbox equivalent to the PAC-5. Now, the PAC-5 is a composite of the MMSE, logical memory delay, digit symbol, the free and cued selective reminding test, and the category fluency test. This composite actually shows a high correlation, even at baseline, for amyloid or tau deposition. And one of the things that we're very interested in is whether or not the mobile toolbox PAC-5, the mobile toolbox PAC-5 could substitute for the PAC-5 in remote environments. And the advantage of that would be a more consistent assessments so that you could truly measure change over time rather than at 6-month or yearly evaluations. So in this study, we had 88 cognitively unimpaired older adults. This study is still ongoing. And all participants had an in-clinic PAC-5 within a maximum of 6 months, as well as the remote administration of the mobile toolbox in their home. You can see that there were, the age of the individuals was around 71. There were a majority of females. They were highly educated. We did a nice distribution for the Boston area of race and ethnicity, and they all scored in the normal range on the PAC. So what did we do? We did a correlational analysis to confirm hypothesized associations with the remote MTB test and the in-clinic PAC-5. All of the analyses controlled for age, sex, and years of education. We did a linear regression analysis of the MTB PAC-like composite with the PAC, and a linear regression of the MTB composite scores predicting standardized in-clinic assessments. In session 2, you're going to hear about its association with amyloid and tau deposition. So what did we find? We found that there were good significant correlations with the PAC-5. You can see that there was a good correlation of the PAC-5 score with arranging pictures, also with the faces and names test, the sequencing test, and the number symbol digit symbol test. All of them were significant. And even with executive functions, the arrow matching test and crystallized intelligence with spelling and word meaning. What wasn't correlated but was trending was the shape color sorting test. It's unclear why that is the case. Maybe it's an easier test to do, but otherwise there are many lovely correlations with paper and pencil PAC-5. Then we wanted to theoretically determine what would be the tests on the mobile toolbox that kind of matches what we do in the PAC-5. So we picked 2 episodic memory tests similar to the PAC, which has the logical memory and the free and cute selective reminding. And in this case, we chose arranging pictures and faces and names. There's a digit symbol test on the PAC, so we picked number symbol match. And then there's an MMSE, and we didn't have an MMSE cognitive composite, so we decided to use the vocabulary. And what you can see here is that there was a fairly good correlation with the PAC-5 score along with the MTB PAC-like composite, and even with linear regressions correcting for age, sex, and years of education. So we think that the remote MTB PAC-5 might be a good substitute for clinical trials, and I'm very excited about that. But can we get it down to fewer tests that the individual has to give? So like the MyCog, which got it down to 2 tests, we did a study looking at what if you had a 3-test composite or a 4-test composite, 5-test composite, 6-test composite. And you can see down at the bottom, if you do 3, it's only 12 minutes. If you do 4, it's 15 minutes. If you do 5, it's 18 minutes. And if you do 6, it's 20 minutes. So the researcher or the clinical trialists have opportunities to decide which tests they think would be less burden in their clinical trial. And what you can see is that all of them were significantly correlated. Obviously, of course, if you do many more tests, you have a better correlation. But you can see even the 12-minute test was decent for your clinical trial. So what are some of the drawbacks, the feasibility, the technical difficulties that are needed in doing this remotely? So we had 88 participants, and they were of all ages, some going up into their 80s. And participants, there were 17 or 19% of participants that needed some assistance, troubleshooting over the phone by a research assistant to complete their MTB assessments. And what was the kind of help they needed? Some of them needed help in downloading the MBT app, some in logging in. So we always had a live person available to all of our participants should it be needed. However, the majority, as you can see, of participants were able to do it on their own. Those who needed assistance were often significantly older, so they were the ones that were 77 to 84 years of age. And the younger participants, of course, needed no assistance. So as time goes on, we're going to be able to see that the mobile toolbox, as all of us baby boomers get older and older, are not going to need much assistance at all. And that bodes well for the primary care setting, that people will be able to do it in the waiting room or even at home with ease. And 59% of our participants completed their assessments within the 2-week time frame. You have to tell people, and I got to tell you, elders are busy people, who participate in research. So we had to sometimes remind them that you have 2 weeks to do this, and most of them did it without any reminders. However, 41%, because they were traveling or off in Florida, needed calls. We were in Boston, so out in Florida, needing calls to complete their assessment before their assessment expired. And I got to tell you, only maybe 1% of individuals, once they got the reminder call, didn't complete it. However, needing assistance or reminders was not associated with years of education, so it doesn't matter how long you've been in school or how smart you are, and it was not associated with baseline cognition. So I think, in conclusion, that the mobile toolbox is the next generation of cognitive assessments, along with the other assessments that you're going to see. I'm really grateful to the NIH for this effort, and also for Molly Wagster and Richard Gershon for leading the effort in bringing remote assessment to the world. Thank you very much.
So we're going to give the tech people just a couple of seconds to get Dr. Adolph's system set up, but I will be introducing her momentarily.
Don't change the source, please. Thank you.
Okay, so thank you for your patience. All of you have heard a little bit already today about the Baby Toolbox, the NIH Baby Toolbox, but Dr. Adolph will be giving us a presentation briefly. And I just wanted to point out that the Baby Toolbox, the NIH Baby Toolbox, has some unique innovation. In particular, obviously, you can't ask a 1-month-old questions where you expect a verbal answer. You need to be able to find some innovative ways to assess infants in particular, but infants and toddlers, especially very young toddlers. So the Baby Toolbox was the Northwestern team and the scientists involved in assessing were very innovative in developing these, essentially using the iPad similar to a Toby system for assessing with video and with the ability to identify eye tracking or gaze detection. So this was a really highly innovative adaptation that the contractor, Northwestern, Dr. Gershon and team, had to overcome very quickly once they were selected as the contractor for this tool. So we were really excited with, out of the box, starting right off the top, highly innovative approach to assessing children, particularly infants. I will say that Dr. Adolph has been a key player in developing motor assessment in both the NIH Toolbox and the Baby Toolbox, the NIH Baby Toolbox. She is the Julius Silver Professor of Psychology and Neuroscience and professor of applied psychology and child and adolescent psychiatry at New York University. She also directs the NIH-funded Databerry Video Library and the Play Project, which has been really exciting to watch the progress of those two grant awards. And she maintains the DataView video coding tool. Dr. Adolph uses observable motor behaviors in a variety of technologies, including video, motion tracking, floor instrumentation, head-mounted eye tracking, EEG, etc. She's been innovative in using everything you can think of to try and assess particularly very young children and their motor assessment. She's been a wonderful collaborator. She's been engaged in many, many different projects, and we're delighted to have her today introducing you to the NIH Baby Toolbox. So thank you, Karen. I'm going to go ahead and sit off stage.
Do what? Yeah. So Northwestern got awarded the contract under the leadership of Richard Gershon, and then Richard assembled a team of domain leads across 6 institutions to develop the new battery for young children. The resulting developmental battery is called the NIH Infant and Toddler Toolbox, or the Baby Toolbox for short. And it provides cutting-edge assessment tools for children from 16 days of age to 42 months. It's going to be publicly available in late 2024. The Baby Toolbox is a neuropsychological battery with cognitive, social-emotional, and motor assessments, and it's intended for use in research and clinical settings. The Baby Toolbox is going to be available in English and Spanish. It includes primarily direct assessments and behavioral observations with some supplementation by parent report measures. And everything is administered on a digital tablet, just like the NIH Toolbox. The Baby Toolbox stands out against competitors because of its innovative assessment technologies. So we use real-time automated scoring, like you push a button and you get the child's score immediately. We use gaze tracking to enable testing of really young infants, and video capture of behavior for both immediate review and annotation of behaviors that are too fast or too tiny to be seen with the naked eye, and also for export, for offline analyses, and for long-term storage of the behaviors. In contrast to other instruments, all of the manipulatives in the Baby Toolbox are available through general purchase, so users don't have to buy expensive or hard-to-find items. This is the Baby Toolbox at a glance. So it covers all the major neuropsychological domains. It's in English and Spanish. It uses a variety of assessment approaches, and it uses a variety of truly innovative technologies for assessment using only manipulatives that you can find anywhere. The original contract identified 6 domains that are critical for early development. Each domain is led by a scientific domain expert and then supported by a team of expert consultants. The 6 domains are grouped into the same domain structure that's used by the NIH Toolbox: cognitive,
social emotional, and motor functions. Each domain team selected measures that were appropriate for infants from 16 days to 42 months. The measure selection was informed by an expert survey that provided information about what measures we should use and what domains they should be in and what the cost should be and what the length of administration should be. We also conducted a scoping review that began with 37,000 texts to identify the most common measures used in the literature to inform our measure selection. So I want to show you examples of some of our measures. In the cognitive domain, we have 16 measures. These are primarily direct and observational. Many of the tasks include two versions, so gaze measures for babies under 2 years of age, and then touch-based measures for children that are older than 2 years. Behavioral observations are recorded by the administrator, and the cognition domain also includes a widely used parent report measure for 2 of the 6 language assessments. Gaze detection allows for direct assessment of the youngest babies who can't talk, they can't even point. Gaze detection uses the front-facing camera and the built-in software of a standard iPad Pro. The technology is cheap, it's easy to use. This software can detect faces, it can identify eyes, and it can estimate where babies are looking. And then the resulting data are used to distinguish if this baby is looking on or off the screen. It can quantify the percentage of looking to one of 2 images. And it can identify, a look that can trigger gaze contingent responses. All the gaze measures follow the same procedure. So first, the administrator places the iPad to track the child's face. Then we calibrate the software by getting the child to look at the 4 corners of the screen. And then finally, we present the test items for that particular task. I want to show you an example of an administrator setting up a gaze measure called looking while listening. This tests receptive language. So the babies see 2 items on the screen, and one of those items is labeled.
Where is the nose? See the nose? Do you see the cup? Look at the cup. Where is the shoe? See the shoe?
Here's an example of Here's an example of a touch-based task called visual delayed response that tests attention, executive function, and working memory.
Look. How about this one?
Where is it hiding? Touch where it is hiding.
So we have a gaze-based version of the same measure where if the baby looks at the right place on the screen, the creature pops out. This is an example of a behavioral observation. It's called object counting, and it assesses counting and cardinality. So the child counts some set number of objects, and then the administrator directly records their verbal response.
How many are there?
1, 2, 3, 4, 11.
In the social emotional domain, we have 14 measures. We get parent reports of children's temperament, their negative affect, their self-regulation, and so on. And there's a highly engaging interactive test of joint attention, play, and pro-social behaviors. An examiner-facing screen guides the administrator through the interactive task. On the left are all the steps for the administrator, and on the right are all the scoreable behaviors. So I'll show an example of one part of the interactive social observation task. You'll see the examiner offer prompts, and then you'll see her score the behaviors that the child demonstrated.
Ezekiel, look. You found the car. Ready? Vroom. Vroom, vroom, vroom. Beep, beep. Ready? Here it comes to you. Vroom. I'm giving it to Mama. Beep, beep.
So the experimenter, the administrator, notes that this child responded to his name, he responded to a point, he smiled without looking, and he did a showed the object to his mother. In the motor domain, we have 3 measures. They're all video-based measures, and each measure has variants of the tasks, so it can span the entire age range. Get up and go tests locomotion and postural transitions, including rolling and lifting the head and trunk while prone for the youngest babies. Reach to E tests reaching and grasping across the age range, and it also tests tool use and planning in older children. Sit and stand tests stationary postural control, and it's similar to the standing balance tasks in the NIH Toolbox. I'll show an example of an older child doing get up and go.
Ready?
1, 2, 3, go!
15.
Yay! Yay! Okay, now we're going to go back. Come on. But Mama's going to go over there. Okay, I got it. Okay.
25.
Ready? Go get Mama. Go get Mama.
30.
As soon as the child finishes, the administrator records their behaviors based on an immediate review of the videos. So, for example, the administrator records how the child got off their back. Each option is accompanied by a line drawing, so the administrator can just match the behavior that they're looking at in the video to the options that are illustrated in the line drawings. So here, this child got up without rolling. Here's how we score the measures. We used 3 different scoring approaches based on the measures and on the data. Unidimensional or traditional IRT is just like the scores that you get from the regular NIH Toolbox. Each test generates 1 score, and the scoring accounts for how strongly the item relates to underlying ability and how difficult that item is relative to other items. Because some of the tests generate more than 1 score, we also use a map calculator. So like traditional IRT, this approach also accounts for item difficulty, but it can generate multidimensional scores. And finally, we use traditional scoring methods. For example, the number correct or rank-based scores. And these are used for measures for which an IRT model didn't fit or was inappropriate. The final data are going to include measure-level scores, age-corrected normed scores, domain scores, and item-level data if the researcher wants it. Like the NIH Toolbox, the Baby Toolbox will be available in both English and Spanish. To develop the Spanish version, we translated everything that the examiner sees, everything that the child or the caregivers see, And all the audio content, like how many are there and where's the nose, we translated all of that into Spanish using a third-party vendor. Forward and backward translations were conducted by 4 independent translators to come up with a final version. The goal was to use a general version of Spanish rather than vocabulary that's specific to certain countries or to certain regions. And then the translations were then reviewed by Baby Toolbox Spanish-speaking scientists, staff, and Spanish-speaking content experts. For the language domain, the Spanish versions were not just direct translations. Instead, we developed both versions in parallel to ensure that the Spanish version followed language-appropriate rules and was culturally sensitive. For example, in the Looking While Listening task, both the English and Spanish versions match items based on a lot of criteria like when they emerge in development and the starting consonant sound. But for the Spanish version, we also matched each pair of items based on their gender. So although the pair book and nose are good for English, they didn't work for Spanish because nose is feminine and book is masculine. So we created language-appropriate items.
There is the nose. See the nose?
Mira la nariz. ¿Ves la nariz?
We're in the final stages of completing the analyses for our validation and norming studies. The instruments were normed with a national sample of 2,550 children, about 500 of whom did the Spanish version. We created the sampling plan using the 2019 Census Bureau American Community Survey, and we had enrollment targets for age and gender that were nested within geographic census region and other relevant demographics. These are our 16 testing sites. To ensure reliability, we re-administered the whole Baby Toolbox to a subset of children within 7 to 10 days of their original test. To evaluate convergent validity, we administered 2 external instruments, the Ages and Stages Parent Report Questionnaire and the Bailey Scales. To explore clinical feasibility, we collaborated with 3 sites that work with clinical populations, and each of these sites is piloting a small set of children. We're in the final stages of data analysis. Our forthcoming results will include the psychometric properties of the Baby Toolbox, such as the correlations with age, with external measures, and the internal and retest reliability. A lot of that data is already analyzed, and it'll be presented in detail at other presentations at this conference. So to learn more about the Baby Toolbox, please come to session 1 from 1 to 2 o'clock today. The session describes 3 of the 6 domains in more detail, and it includes implementation of the Baby Toolbox in the HBCD study. We also have 2 posters at the poster session presenting additional data from the norming study. And in addition to the scientific teams who contributed to each domain, there's a fabulous, awesome, magnificent team at Northwestern who made all of this possible. And here's the contact information for Richard Gershon, who's the PI of the Baby Toolbox.
So it probably has not been lost on most of you in the room that we're a full 30 minutes ahead. But we are going to take a break now, And we're going to extend the break, and I will ask that people return at 11 for another talk before lunch and some announcements. I just wanted to remind those of you in the audience that if you weren't able to pick up your badge on the way in, to please do so now at break so that we can get an accounting of the individuals who are here. Also, I think many of you may know by now, but the Natcher Cafeteria opened for this conference. So if you need a cup of coffee or a snack or something, please go up to the Natcher Cafeteria on the first floor, the main floor. Lunch will be served there as well. So we'll take a break now. Thanks very much for your attention, and we'll see you at 11. All right. Hello again. For those of you who may be joining us virtually or even here in the room who may have just joined, I'm Molly Wagster with the National Institute on Aging, where I serve as Chief of the Behavioral and Systems Neuroscience branch in the Division of Neuroscience. I was the lead project officer for the NIH Toolbox contract and continue to work with Northwestern University investigators for continued oversight of expansion and development of the NIH Toolbox. And I also serve as one of the project scientists for the Mobile Toolbox Cooperative Agreement. My presentation this morning is aimed at highlighting some of the large initiatives that have or are currently collecting phenotypic data using one or more of the measurement systems featured at this conference. The uptake of the measures by these studies, I think, indicates the widespread and growing adaptation of these measures and illustrates the positive impact of having common measures across studies. And then resources for secondary data and analytic studies have been generated, and I will expand on these as well. So the title of my talk is Use of NIH Toolbox and Related Assessments in Large Initiatives, Resources for Research. The NIH Toolbox for Assessment of Neurological and Behavioral Function, which is the full name of the measurement system, was designed to develop a standard set of instruments to measure neurological and behavioral health across the lifespan that, when adopted and used broadly, would allow for comparison across studies and maximize utility of the data. The NIH Toolbox, which was developed through a contract supported by the NIH Blueprint for Neuroscience Research, was normed in almost 4,900 participants at sites throughout the country and who were representative of the U.S. population based on gender, race, ethnicity, and socioeconomic status. As you heard earlier this morning, the NIH Toolbox includes brief, psychometrically sound measures that were validated and normed in individuals aged 3 to 85 years of age in the domains of emotional, motor, sensory, and cognitive performance. Both an English and Spanish version were created as part of the original contract requirements. And in particular, to note, I think, all 4,859 individuals in the norming study contributed data for all measures in all domains. These extensive and rich data from norming are available for secondary analyses and may be accessed through the Harvard Dataverse repository. Through a separate award, funding was secured to collect saliva samples from over half of the norming sample, almost 2,700 individuals, across the age span enrolled. DNA was extracted, and the samples have been stored at the Indiana University School of Medicine and may be accessed for research. Sufficient amounts of DNA are available for multiple types of genetic analyses in conjunction with the phenotypic data that was gathered. In the box at the bottom of the slide, you can see that slightly over half of the samples were from females, 29% from Hispanic individuals, and 16% from Black. I want to point out that the numbers in parentheses reflecting the actual number of individuals that are in each of these categories. Again, to note, for these individuals who contributed DNA samples, they were assessed on every measure in every domain of the NIH Toolbox. Again, a very rich resource, I think, for investigators to explore. In 2017, the National Institute on Aging issued an RFA, a request for applications, designed to establish the measurement properties of the NIH Toolbox in individuals with amnestic mild cognitive impairment and early-stage Alzheimer's disease, and in individuals over age 85. So recall that the original contract was to develop measures for the age span of 3 to 85 years, and it was to develop measures to assess health and not to develop screeners for disease. So the study, Advancing Reliable Measurement in Alzheimer's Disease and Cognitive Aging, it goes by the acronym ARMADA, which is a bit shorter to say. The goal of ARMADA is to establish a research resource that facilitates detection of disease at the earliest stages, that can detect change in function over time, and that could be used to track success of prevention and therapeutic interventions. Clinical trials for Alzheimer's disease now focus on much earlier stages of the disease, including the preclinical or precognitive impairment stage. However, not all measures of cognition currently used in Alzheimer's disease clinical trials are necessarily sensitive at these very early stages. In fact, performance on some of the non-cognitive domains, such as motor performance or emotional function, may help to differentiate normal age-related change in cognitive performance from mild cognitive impairment or from early-stage Alzheimer's disease. So while this is not the only example to date of validating some or all of the NIH Toolbox measures in disorders and disease, it is one of the first. By design, ARMADA was largely conducted in individuals who were enrolled at Alzheimer's disease centers across the U.S. The data amassed from the validation study will be available for secondary analytic studies through the Harvard Dataverse repository that I just mentioned. This is what I understand, and it will be linked with the accompanying neuroimaging, genetic, and other data that were collected on these individuals through the Alzheimer's disease centers. So another, I think, excellent opportunity for further exploration given the data that is available. The Human Connectome Project, which was a groundbreaking NIH Blueprint initiative, was undertaken to elucidate brain connectivity in relationship to behavior and contributions of genetic and environmental factors to individual differences in brain circuitry. The original study for the, I think I jumped ahead too soon. I will come back to that slide. The original study for the Human Connectome Project was conducted in 1,200 adults aged 22 to 35 years for the phenotypic data collection, measures from all domain batteries in the NIH Toolbox, motor, sensory, emotion, cognition, were employed. Now, not every measure in every battery was used in the original Human Connectome Project, but certainly measures from each, at least some measures from each of the batteries were used to collect the phenotypic data. After the Human Connectome Project was launched in 2009, with awards following in 2010 for the Young Adult Connectome Project, that was the one that I just mentioned, there have been 18 additional connectome studies that have been supported, 4 of them under the umbrella of lifespan connectome projects, and 14 under the umbrella of connectomes related to human disease. A few of these I've represented here on the slide, but certainly, obviously, not all 18. The studies range in size from 100 to 1,500 participants, and they cover a wide range of developmental stages, as well as neurological diseases and mental health disorders. Besides the Young Adult Connectome Project, select NIH Toolbox measures have been used for data collection for many, if not all, of these subsequent connectome studies. Details about these studies and how to access the data for secondary analyses may be found on the Connectome Coordinating Facility webpage. The NIMH Data Archive, or known to some of you as the NDA, houses the data. I don't know what happened. Can someone help me with the slides? I don't know why this, I must have accidentally touched a live, okay, thank you. All right, so anyway, just to repeat, the data from the original Human Connectome Project study in young adults, as well as the 18 other connectome projects that have spun off from that, are available through the NIMH Data Archive, and many, if not all, of these studies have employed measures that were pulled from the NIH Toolbox. All right. The goal of the Adolescent Brain Cognitive Development Study, or ABCD, is to increase the understanding of factors that can enhance or disrupt a young person's life trajectory. This long-term study of brain development and child and adolescent health has recruited over 10,000 children ages 9 to 10 and is following them into early adulthood. So it's a longitudinal study. ABCD integrates structural and functional brain imaging with genetics, neuropsychological, behavioral, and other health assessments, including measures from the NIH Toolbox. Data collected through ABCD currently is shared through the NIMH Data Archive, and a link is provided here on this slide. Again, another opportunity, another resource for secondary data analytics studies. The Environmental Influences on Child Health Outcomes, or ECHO, study is a large NIH-supported initiative that involves 84 existing longitudinal cohort studies representing 40 states and Puerto Rico, and for which over 64,000 children are being followed. The goal is to advance our understanding of the effects of a broad range of early environmental factors and exposures, including physical and chemical, psychosocial, behavioral, and biological, on health outcomes for children. The study incorporates NIH Toolbox measures for assessing behavioral outcomes. Starting in 2025, the mobile toolbox additionally will be used to capture data remotely from 40,000 caregivers involved in this study, as well as from an estimated 5,000 ECHO participants, current ECHO participants, who will be transitioning from adolescence to adulthood, that is, after they turn 18. Also, starting in 2025, it's my understanding that an estimated 10,000 children will be assessed using measures from the NIH Baby Toolbox, and I will be discussing that in the next slide. So the goal of the NIH Infant and Toddler Toolbox, also referred to as the NIH Baby Toolbox, is to develop brief, standardized measures to assess neuropsychological, cognitive, and social function in infants and toddlers ages 1 to 42 months. I know many of the things I'm saying right now you've heard already this morning, but I think it bears repeating to put this in the context of the kind of data that we have available. So similar to the NIH Toolbox, the Baby Toolbox is being developed through contract, supported by the NIH Blueprint, and is being led by the National Institute for Child Health and Human Development, with Kathy Mankepke as the lead project officer. The development of the measures was conducted in over 2,500 infants and toddlers, plus parent partners, from both English and Spanish-speaking households. All norming data will be deposited and available for secondary analyses. The location is still to be determined. For an announcement of the availability of the data resource, please check the NIH Blueprint website or the NIH Baby Toolbox site in the coming months. So another great opportunity for secondary data analytic studies. And for a final spotlight, the largest long-term study of early brain and child development in the U.S., the Healthy Brain and Child Development, or HBCD study, plans to enroll approximately 7,500 participating families and follow them from pregnancy through early childhood. The goal of HBCD is to understand how the brain develops and is affected by exposures to opioids and other substances such as alcohol, tobacco, cannabis, how the brain responds to, or is affected by exposures to these things, also to stressors, trauma, and other significant environmental influences, including those that may promote resilience. The study actually stems from the HEAL initiative, which stands for Helping to End Addiction Long Term, and actually composes the HEAL of the Healthy Brain and Child Development name of this effort. So through this presentation, I hope I've been able to bring your attention to the widespread and increasing use of the measurement systems that are featured here at this conference in these large NIH-supported studies, as well as the rich and accessible resources that are being created that I think will be, very instrumental for us for future exploration and for discovery. So thank you for your attention. Now, I know that we've all been very fast today, so I think that that's a good thing. More time for conversation and for lunch. But I do have an important announcement that I want to make and a few housekeeping things. I'm going to deal with the housekeeping things first, and then we'll go on to the announcement. So, we're about to go on lunch break. That will be till 1 p.m. At 1 p.m., we will start our concurrent sessions, and these will be, I'll announce where those are going to be held in just a moment. For those of you who are attending the conference virtually, you will be able to access these concurrent sessions and listen to the talks, and you also will be able to move from room to room as you wish in order to hear the talks. And, of course, for those of us who are here in person, we can easily move around and participate in the presentations. As I said, lunch break is until 1. The Natcher Cafeteria on the first floor is open for lunch. I also wanted to bring to your attention something that is in the program, but we haven't really discussed yet at this conference. Again, the conference intention is for education and dissemination primarily, to be able to get out to the community, the research community, extramural staff such as myself, NIH intramural program staff for use in their own research, the widespread extramural research community, the clinical community, industry, and even educational outlets for trying to bring to your knowledge an understanding of these measurement systems, what's in them, how they work, how to access them, and get that information out. So this afternoon, during the poster session, and tomorrow morning, during the live demonstrations that will be held, we have groups of individuals who will be manning tables for an Ask the Experts session. So this will be this afternoon during the poster session, as well as tomorrow morning during the live demonstrations. And so we encourage any of you here in person to avail yourselves of these individuals. They will be set up by measurement system, and we'll be happy to answer your questions, or if they don't have the answer ready, they will be taking down the question, and we will get back to you after the meeting. Also, and I don't believe that it has been displayed, and I know that it's not on the next slide, so I won't put that slide up here, but also we have an email address for which one is able to submit any questions for specific speakers or just in general. This can be from the virtual attendees as well as for those of you who are here in the audience. That email address is NIH Measures, CONF, so NIH, measure spelled out, CONF, at mail.nih.gov. And later today and this afternoon, we will be displaying that email address on the slides. But I just wanted to bring that to your attention so that there are, again, you know that there are ample opportunities for you to interact, ask questions, and get your questions answered. Questions will probably not be addressed during the during the meeting, unless you're talking about the Ask the Experts. But those questions going to the email address will be answered and taken care of after the meeting is over, in the days and maybe a couple of weeks to come after the meeting is over. But we do intend to answer each of these individually. All right. Now, this is something that I know has been weighing on everyone's mind. So I just want to make sure that you understand that we have timed this conference so that you will have ample opportunity to participate in the solar eclipse. So, thank you. This is the only way I can get applause. Okay. So as you know, today marks a solar eclipse, which here in Bethesda will be about 89% of totality. I've been spending a lot of time Googling this, and so I think I have all of the facts. It will begin here in Bethesda at 2:04 p.m. That will be while we are in the concurrent sessions. The maximum will be at 3:20 p.m., and this is while we will be on break before we go to the poster sessions. So feel free to go to the atrium level where the posters will be and the Ask the Experts will be, and even outside if you wish. The eclipse ends at 4:32 p.m. This will be while we're in the poster session, but believe me, if you haven't already been on the atrium level and sort of looked, it's floor-to-ceiling windows. You can easily access the outside, so it'll be perfect viewing, at least if you don't look directly at the sun, for the eclipse.
Will you distribute glasses?
Well, you know, there wasn't anything in the NIH budget for that, but you'll have to create your own pinhole, I guess, Bruno, and look at it that way. All right. So I did want to make an important announcement. So as we were putting together this conference, we wanted to acknowledge the opportunity to bring in more junior investigators, people who may be using some of these measurement systems in their work, but sort of starting out in their career. And so we had the opportunity to make travel grants awards, 10 of them, in fact, to individuals who submitted an abstract for either a poster session or a platform, meaning one of the concurrent sessions today. So I just wanted to take a moment to recognize these individuals who have come from far and wide, and we really appreciate them being here and participating and bringing their information and knowledge to this meeting. We have Oluwayomi Aoko from University of Lagos. Dr. Aoko. Callie Tyner from University of Delaware. Callie, in the back. Kelly Watson from Vanderbilt University Medical Center. Where's Did Kelly stand up? Kelly Watson? Oh, there she is. Okay. Amanda Cook-Mayer from University of Michigan. Amanda. Gail Harmata from University of Iowa. Gail, thanks. Jody Charvis from University of Rhode Island. Jody's in the back. Lindsay Becker from the Niswonger Center and Department of Psychology at Ohio State University. And I'm missing her, but... Oh, okay, sorry. There are bright lights in my eyes. Okay. Amanda Flagg from University at Albany State University of New York. Shreya Arun from Virginia Commonwealth University. Shreya. And Li Wan Yen from University of Illinois, Chicago. Okay. Thank you so much. All right, so before we break for lunch, I just wanted to announce or remind you, it should be in your program, but the concurrent sessions, which will start at 1 o'clock, session 1, which is on the NIH Baby Toolbox, will be held here in the main auditorium, where we are right now. Session 2, which is on the mobile toolbox, will be held in Balcony A, which you can access through the atrium level, one floor up. And session 3, which is, it will be focused on MyCog, which is also 1 floor up at the atrium level in Balcony B. So I hope everyone enjoys their lunch. Look forward to seeing you back in the concurrent sessions at 1 o'clock. And if we miss each other for some reason, see you tomorrow for the demonstrations and the rest of the programming. Thank you.
So I'm Kathy Mankepke from Child Health and Human Development, and this is concurrent session 1. So on the NIH Baby Toolbox, we will have 4 presenters and then a little bit of time for questions. So I welcome everyone to join us. I should have introduced myself. I am Kathy Mankepke. I am a program director at NICHD, and I also am the contract officer representative, program manager for the NIH Baby Toolbox. So I'm delighted to have our first speaker, Catherine Hahn. And I will introduce you. Give me a second here to rearrange my papers. Dr. Hahn completed her PhD in cognitive psychology at Northwestern University in Dr. Paul Reber's lab in 2023. So she is a new postdoc. She's now a postdoctoral scholar at the Medical Social Sciences Department at Northwestern University. Dr. Hahn has been an active member of the the Northwestern University NIH Baby Toolbox team, and specifically working on executive function and cognitive measures. So welcome, and thank you for being here.
Thanks, Kathy. Happy to be here. And do I just click to go next? Okay, perfect. All right, let's get started. Hi, I am Kat Hahn. I am a postdoc at Northwestern, and I have been privileged to contribute to work on the Baby Toolbox. And today we're going to focus on some of our progress and updates specific to the executive function and cognition domain. So executive function and cognition, or EFCOG, here on out, covers top-down modulation of goal-directed activity and memory within the cognition domain. This is a super important domain, and children impairments or delays in EF development have been linked to ADHD, ASD, conduct disorder, and other psychiatric conditions. So here, for our purposes, EFCOG measures in the NIH Baby Toolbox aim to assess this domain. And I'm going to cover in today's talk measure selection and some preliminary results from a norming study that recruited over 2,500 infants across the U.S. So in terms of measure selection and administration, a lot of work was put into task selection via a team of domain experts, an expert survey, as well as a big scoping review. And we landed on a few tasks. We split this into gaze-based measures for 6 to 21-month-old infants and touch-based measures for the older 22 to 42-month children. And these paradigms for gaze-based follows a familiarization and novelty preference paradigm as well as visual delayed response. And for the touch-based tasks, a memory task and also visual delayed response, in the goal of assessing constructs of executive function, learning, and memory, as well as trying to do all of this in children in about 10 minutes. So I'm going to go over some of the tasks, specifically here for gaze, for the familiarization and novelty preference task. The children see 8 10-second trials of an animal image, such as this dog here. And after that, novelty preference is assessed by presenting the old item from familiarization, so the dog, and a new item, the cat. And we expect that children should pay more attention to the new item, the cat. Spanning both gaze and touch from 6 to 42 months, we have the visual delayed response, or VDR task. And here, a little animated creature pops up on the screen and then hides behind one of 2 sides or 2 boxes on the screen. And after they hide, the curtain closes for a certain amount of time, and that delay is age-based, so shorter times for the younger children and longer times for the older children to scale the task in terms of difficulty. And for the gaze-based version, the goal is to look at the box to reveal the creature that's hidden, and in the touch-based version, to touch the box to reveal the creature. And finally, we have, for the touch version, the memory task. So it follows a narrative that the children should feed the hungry animal as a mechanism to help with learning or encoding the animals on the screen. 2 animals are presented on the left and right sides of the screen at a time. Once the animal is touched, the new animal of the 2, it's no longer hungry. Children do 11 trials of this. The learning and coding portion teaches the task to the children the rule to touch the novel animal. After an 8 to 10 minute delay, the children are exposed to a test portion, which includes 20 trials, including images that were already present within encoding. This test portion also contains what we call dyad items, so familiar items that were present in the first half of the test also make an appearance in the second half. And this is done to kind of ensure that the child isn't sort of forgetting or guessing on these items. And so for measure scoring, we've developed some scoring models, but before that, I'm going to go into our approach into measurement. And this spans most measures that utilize IRT, not just EFCOG. So we aspire to a measurement system that should be conceptually comprehensive and methodologically sound, and produce clinically actionable measure scores. So we expect these scores to be sensitive and allow for meaningful comparisons across developmental stages. So with this goal in mind, we try to assess individuals at different ages under this idea that they can be all measured under a single latent trait or latent variable. And we use IRT, or item response theory, to generate these scoring models. And here in the next few slides, I'm going to present the results from scoring models for specifically the touch-based measures, where we used a partial data set from the norming sample of about 2,500 infants that we recruited. So for the EFCOG scores, we find that for both the memory task, the touch portion, as well as the VDR task, the touch portion, these scores that we generated using IRT correlate well with age and also as expected with age. In the memory task specifically, we just use the test portion. Items are categorized as correct if the children correctly selected the new item for both items in that dyad, so the sort of first half and the second half. And for VDR touch, items are categorized as correct or incorrect simply if the child selected the correct side for which the creature hid. I have some results, preliminary results on external validity that we had done with our scores. So a subset of infants came back to complete the Bailey 4th edition, which is known to be a gold standard paper and pencil assessment of infant development. 120 infants were recruited, and sort of a partial data set are used here to compare against what these Bailey cognitive growth scale value scores. On the y-axis here, you can see our latent trait scores from IRT for each of the EFCog touch measures. And as we can see for VDR touch, as well as the memory task touch version, these scores correlate with the Bailey as expected, showing convergent validity with this external measure. So this concludes our preliminary results and progress for the EFCog domain for Baby Toolbox. I'm going to quickly go over some of our next steps, which include confirming the scoring model with the full sample, including both English and Spanish-speaking participants. And we also plan to do further validity analyses, not just with the Bailey, but also with the Ages and Stages questionnaire, which is a very short, validated caregiver screening report. We also plan to conduct test-retest reliability with about 220 children that were recruited to complete the Baby Toolbox measures, once again, about 7 to 10 days after the first session. And we also plan to conduct validity analyses with the full sample and also reweight that sample to match the 2022 American Community Survey to create age-adjusted norm scores. So I'd like to take the last minute to thank our amazing EFCog team. This was truly a team effort to make all of this happen, not just for EFCog, but also across all the domains and measures. I'd like to also thank the Northwestern Baby Toolbox team, our amazing software development technology team, as well as our SAGO partners who helped collect norming data, and of course, lastly, our funding source, NIH. Thanks.
Is my mic? There we go. Okay. So I'm going to sit over here to be out of the way. I forgot to mention when I was introducing Catherine, Dr. Hahn, that our first two speakers are from Northwestern University and have been significant contributors to the measures they'll be discussing. So I would like to introduce our next speaker, Sarah, Dr. Sarah Pila Lieberman. Dr. Sarah is a research assistant professor in the Department of Medical Sciences at Northwestern University, Feinberg School of Medicine. She earned her doctorate in media, technology, and society at Northwestern University, working in the Center for Media and Human Development. She also holds a Master's of Arts in Child Studies and Human Development from the Elliott Pearson Department of Child Study and Human Development at Tufts University. Her research interests focus on the benefits of prosocial and educational media for young children, particularly in early childhood education. So thank you.
Thank you. I'm very excited to talk to you today about work that I'm doing at Northwestern with numeracy and early math domain. So when I talk about early math and numeracy, we're talking about subdomains of counting and cardinality, shapes and spatial relations, approximate number system or ANS, and number recognition. We also talk about addition and subtraction or arithmetic. We know that these areas are important because they're predictive of later academic achievement and also specifically mathematical academic performance. So again, today I'll describe the development, correlations with age, and external validity of the measures we developed that assess the math domain. So we selected tasks from our domain experts, Douglas Clements and Julie Sorama, and the expert survey, as mentioned, and scoping review. We landed on measures that would fit within our time frame, that were developmentally appropriate, and that we could feasibly create. And so these turned into 4 touch or verbal response-based measures: counting, subitizing, verbal arithmetic, and who has more. These are for children over 24 months. And then the gaze-based measures that are trying to get at the same thing, numerical change detection and spatial change detection for those under 24 months. And I'll talk about all of these in turn. So first, our counting measure is actually made up of two different parts. In the first part, part one, verbal counting, children are asked by the administrator to count as high as they can sequentially. So the administrator will say, how high can you count? Please start at 1 and show me. And here, children, what they count sequentially to, and the administrator will sort of stop them when they finish something. Here, those higher counts receive higher scores as expected. And then in verbal counting, which you might have seen earlier this morning, is a set of 1 to 8 items across 6 different trials, where the iPad will say how many are there when a camera appears. The child will respond in turn, the administrator will record their response, and then the next item will appear. How many are there with 2 trees, for example, and then moving forward to 3 apples, so on and so forth. Each trial here is scored as correct or incorrect, and the two of them together use a special map generator that allows us to get at scores for both verbal counting and object counting into one measure. Subitizing is getting at number recognition for young children. So here, 2 dots appear on the screen. They only appear for 1 second, as they're too short for any child to actually count them, but really get at that number recognition. And then children, the iPad asks again, how many did you see? Children respond to the administrator, how many they saw. The administrator inputs that response, and then we move on. There are 4 items here of different small quantities from 1 to 4. Each trial is scored as correct or incorrect in this one as well. For verbal arithmetic, as the name suggests, there are 5 different trials of small and easy addition and subtraction questions. So for example, the administrator will say, if I have 2 blocks and I find another one, how many do I have now? The child can respond. They also have the opportunity to use blocks as manipulatives to help them, but the administrator does not do that for them. Again, each trial is scored as correct or incorrect to these simple addition and subtraction questions. In Who Has More, which is trying to understand approximate number system, children are asked to touch the side of the screen with the bird that has more objects. So here there are 2 sides of the screen. A bird appears with the 2 different objects, and children are asked to touch after the iPad says, who has more? There's a demonstration item where the administrator actually shows them what's expected, and then a practice item for children to actually practice the touching component of who has more. Then there are 22 live items in which each one is scored as correct or incorrect with a fixed trial order on how many or what ratios should appear at any given time. Our gaze measures for numerical change detection, children are shown 2 streams of images on the left and right, and these basically differ in terms of same, different patterns of dots that you see. So for example, if the ratio is 1 to 3, you'll have 4 and 12, but you'll always have at least 1 stream that has 4, and then same, different, same. And this is using our eye tracking gaze-based software to understand where children are looking on the screen, as you can see in our AR kit gaze capture here. The next one is our spatial change detection, where there are 2 streams of geometric shapes. They each rotate at the same one in two of the streams, and then the third one has one side, the target side, flipped on its y-axis. So I'll briefly show you what that looks like in practice, and it has a little last clip of calibration that you've already seen. So there's music that happens in the background as well. In terms of our norming study and measure scoring, we found that in general, for the 4 touch and verbal-based response options, that children do perform better as they age, which is as expected. Again, these results are from a subset of our participants who completed the norming study to start with, but I'll tell you next steps that we are looking for to go to the entire sample soon. And then we use this partial data set for our scoring model generation. And as you can see, good correlation with age for these items. In terms of external validity, similarly, we had the same subset. We had children complete the Bailey-4, and then while there's no exact comparable measure on the Bailey-4 for numeracy or math, we use the cognitive global scale composite to the GSV as well to map. And it does appear to have good correlations with our measures, verbal and object counting, subitizing, verbal arithmetic, and who has more, even if it's not an exact one-to-one correspondence. In terms of next steps, again, we're looking to confirm those scoring models with the full sample, including both English and Spanish-speaking participants, as the Baby Toolbox designed in both languages. We'll complete further validity analyses with the full sample and with those who completed our ages and stages questionnaire. Plan to reweight the sample to match the 2022 American Community Survey and create those age-adjusted norm scores. And then finally conduct test to retest reliability on those who took the Baby Toolbox and then returned 7 to 10 days later to complete. Another big thank you to all of those who worked on this, and I will be at the demo sessions for Baby Toolbox tomorrow, so happy to answer questions later and there as well, and let you get to play around with these measures. Thank you.
Thank you. Sarah? Sarah, why don't you stay up at the table? And yes, Catherine. Thank you. So our next presenter is Dr. Julie Cable. She is an associate professor of both the Department of Psychiatry and Behavioral Sciences and the Department of Pediatrics, Division of Autism and Related Developmental Disabilities, and the associate director of the Emory Neurodevelopmental Exposure Clinic at the School of Medicine, the Marcus Autism Center, Children's Health, Atlanta, at Emory University. Her research that includes intervention research as well as basic clinical science has focused on the impact of prenatal teratogens such as alcohol, cigarettes, or cocaine on neurodevelopmental functioning throughout the lifespan. Dr. Cable did not significantly contribute to the development of the NIH Baby Toolbox, but as you'll see, she and other HBCD sites chose to use parts of the Baby Toolbox, and we were very delighted to have them as early adopters who provided valuable information and feedback.
So just to clarify, I am just a representative of the Infant Assessment Core for HBCD. It is not all my work here that I'm representing. My colleagues, Alexi Potter and Natasha Oshkmov, are in the audience here who've helped with all this. So HBCD, Healthy Brain Child Development Study, is a prospective longitudinal study that aims to understand the normative development of individuals from birth to 9 to 10 years of age. We're recruiting in pregnancy and then following these prospectively over time. There are two main goals of our study: to address our gap in knowledge about environmental exposures, particularly opiate and other drug use, and how that impacts infant and child development, and then also to improve our understanding of a normal cognitive, behavioral, social, and emotional function from the prenatal period through early childhood, with a focus on the neuroimaging pieces of the study. We are funded by a variety of different agencies, and there was some reference to this in a talk earlier this morning. You can see all the different agencies on this side, and on the other is the big box, which is the NIH HEAL funding that is helping support this project. We want to acknowledge their support and tell them we're very grateful. The HBCD study spans our continent. And so in green, you can see all the different sites that are involved in data collection for this study. In the purplish fuchsia color is our admin center at University of California, San Diego. And in yellow is our data coordinating center. Each site is responsible for enrolling 300 participants. We are challenged with recruiting a sample that's consistent with our U.S. Census data. So there are metrics that are a dashboard that we're trying to meet. 50% of our sample is enrolled in or from general population and should match these metrics that are established for us. And then 25% have a substance use disorder. And then another 25 are designed to match the socioeconomic characteristics of the substance abusing sample. Somebody touched upon the HBCD components, but I'll just briefly mention that again today. So we're interested in a variety of factors and how they affect neurodevelopmental trajectories. So we are looking at things related to the maternal caregiver, adverse early experiences, cognitive factors, biological factors, genetic factors, and psychosocial factors. So we have various work groups who tackle each of these domains and then develop batteries that go through the neurodevelopmental stages. This is a graphic we use to communicate our timeline of events in HBCD. You'll see visit 1 is when we are seeing people prenatally and enrolling them. At that point, we do questionnaires, collect biospecimens. And then when the baby's born, from 0 to 1 month at visit 2, we continue to collect questionnaires and biospecimens. We start doing neuroimaging on the baby at that point and begin collecting biosensor information on the mother and the baby. We then are able to follow and continue those at visits 3 at 3 to 9 months, visits 4, 9 to 15 months, and visit 6, which is this very strange developmental window of 15 to 48 months. And we believe that that will be cut into, but we can't exactly say that until we move into the next funding period. It's around this period, around visit 3, when we start doing infant assessment pieces. In addition to these windows of assessment, we are also doing visits at 5, 10 to 17 months, visit 7, 16 to 15 months, and visit 8, 36 to 60 months, and those are remote visits. Our sampling procedure is designed to allow us to cover the entire developmental span. And so we are doing these jittered visit windows where participants are assigned to one of these sort of pockets. And you'll see here if a baby's assigned to this top level, so they'll be seen in that 3 to 8 month window at this time period. These are assigned at birth, that they will then be seen at an early window for the 9 to 14 month visit, and then randomly to one of these other components for the 15 to 47th, and similarly along these lines for that one, as opposed to this person who's at the later part of the 3 to 8 month window, then at the later part of the 9 to 14 month, and then will be randomly assigned to one of these slots along the path. So the nice part about that is that it allows us to sample a broad range of development. The hard part is we have to have developmental batteries that sometimes, because of the developmental changes, are not going to be exactly the same at different visit levels. Our work group, the Cognitive and Language Work Group, determined domains that we were interested in assessing. So these are sort of representation of the domains that we opted to assess: sensory processing, memory, executive function, neuromotor function, language, numeracy, visual spatial reasoning, and adaptive function. We opted to use the baby toolbox, or the NIH Infant and Toddler Toolbox, because we wanted to take advantage of the developmental neuroscience that's gone into the development of this instrument. And we thought it would map well or dovetail well into the ABCD efforts to map neurocognitive function to brain as we progress forward in this study that's going to move up into 9 to 12 years of age, or 9 to 10 years of age. In addition, we are collecting other measures. And so when you think about potential validity studies for the baby toolbox, I think you could tap onto some of our measures that we're also collecting. So we're doing the Bailey scales of infant and toddler development at the fourth edition at visit 4, so between 9 to 14 months. We're doing sensory processing measures at visit 3 and visit 5, the MacArthur-Bates Communicative Development Inventories at visit 5, and then every 6 months to 30 months of age. We're also doing the deferred imitation at visit 6, and then I've got this visit 8 with a question mark, assuming that we get to divide up our visit 6 into something reasonable at some point. And then the Vineland Adaptive Behavior Scales we're doing at visit 5 and visit 7. This is a map showing you each of these developmental pockets that we are doing each of these. We're doing the Mullen expressive and receptive measures at visit 3, and then at visit 6, and then visit 6 or 8 again. The visual reception at visit 6 and visit 8. And then we're doing the gaze task, looking while listening, which will transition into picture vocabulary, the executive function, and the numerical change detection, starting at visit 3, throughout visit 4, and then visit 6, and then they'll move into the touch tasks. So here's a timeline of our training. We started in July of last year, and Miriam Novak from the Baby Toolbox group trained our measure experts. And our measure experts at Emory and Vermont went back and trained their staff. We then did an overall HBCD staff training via Zoom, 2-hour blocks, 2 times. And Miriam provided that training. And then our RAs submitted their tapes to Miriam and got certified. And then they helped with certification for the entire staff. So all HBCD staff were able to submit certification videos in September of 2023. And then in November 2023, we had our first V3 pilot when we initiated infant assessments. And then as of March 14th, when I had to submit the slides, or near the date I had to submit the slides, we had 27 people who are certified across 23 sites. 2 sites had passed the adult protocol, but still had to work on the child assessment protocol. I'll share with you some of our training components. So part of the training is to first get checked off doing the Mullen items with an adult to show that you know how to administer the items. The second is a review of the Mullen and gaze measures with an actual child. And you can see here the pass rates are relatively high, 69.8% for the adult technique. But it goes down to 52.8% for the child, and we really think that there is a heavy burden that post-baccalaureate individuals, which predominantly makes up our workforce of research assistants, in struggling in dealing with infant assessment, dealing with the baby, managing their behavior through the protocol. But we do want to point out that the Bailey 4 went through a similar procedure, and their success rate is 36.5%. So we got a slight advantage over the Bailey here in the training process. When we look at average number of videos it takes to get certified, for adult it's 1.24, for a child it's 1.64. So you can see doing that child still adds that additional element of managing that baby through the procedure. In addition to the trainings provided by Miriam, we're doing regular updates on RA calls. So when we see videos where there's a problem, we go to the whole RA group on a weekly basis and say, here's these problems. We want you to make sure to watch out for this so you don't fail your assessment. We do neurocognitive office hours every Thursday, so the 3 of us staff that periodically. You might not have everybody every day, but one of us at least is there every Thursday. And we answer questions from the RAs through all those sites that are involved in the project. We also generated tips for fussy babies, and that's an ongoing area of development that individuals who don't have infant assessment experience need additional support in. And then we do one-to-one meeting with staff as needed. We're interested in monitoring fidelity and reliability over the course of the study, so we're going to make sure we do a peer-to-peer model where they're going to check each other's videos on the 10th administration and every 20 thereafter. This will allow us to monitor site problems, individual assessor problems, and then item level problems where the whole staff need to be retrained because we're making frequent errors in a certain area. The last slide is just simply a notice. You don't have to understand this whole thing, just the part where it says public access at the end in the pinkish color area. This is open science. All of our research is going to be available for people to download. Our first anticipated available data is sometime early next year. I don't anticipate there'll be a lot of infant assessment material, if any, in that because we're locking the data as of July and there's not a lot of V3 stuff yet. So that's it.
Thank you very much. We really appreciated having someone who was not one of the tool builders, but was also willing to give us early feedback. Early adopters are always a very valuable cohort in tool and measurement development. For those of you who were in this morning's session, you have already heard my introduction to Dr. Adolf, but I'll repeat it again. Dr. Karen Adolf is the Julia Silver Professor of Psychology and Neuroscience and the Professor of Applied Psychology and the Child and Adolescent Psychiatry and a Professor of Child and Adolescent Psychiatry at New York University. She also directs the NIH-funded DataBrary Video Library and the Play Project and maintains the DataView video coding tool. Dr. Adolf uses observable motor behaviors and a variety of technologies, including video, motion tracking, instrumented floors, head-mounted eye tracking, and EEG, among other measures, to study the developmental processes. As I mentioned earlier today, and as you will hear again now, Dr. Adolf has been a key player in developing all the motor assessments in both the NIH Baby Toolbox as well as the NIH Toolbox. Dr. Adolf has been a valuable asset to the Baby Toolbox, and we're very glad to have her present.
Thank you so much, Kathy. So I'm going to tell you about video-based assessment of motor development for the Baby Toolbox. Now, existing methods of measuring motor development in children rely on subjective assessments from experts who have extensive training, or they require expensive and cumbersome recording technologies to track children's movements. But we came up with a way for non-experts to quickly and objectively assess children's motor development using just an iPad and a few commonly available items like a measuring cup. We leveraged the video capabilities of the iPad to record and code children's behaviors in real time. And the use of the video is super cool because administrators can capture behaviors that are happening too fast for them to see with their naked eye, and then they can quantify the timing and the speed of the movements, and they can export the videos for further analyses. First, I'll show you the get up and go task of posture and locomotion. The get up part tests critical postural transitions. The and go part tests locomotion. This is an example of get up and go being recorded on the iPad in a home. So for babies who can crawl or can walk, the administrator puts them down on their backs and then encourages them to get up and go to their caregiver. And then they'll go up and then they'll get down from a stair height platform. Then the app prompts the administrator through a series of questions about each behavior in sequence, like how did this child get off their back? The administrator can scroll through the video to see what the child did to know how they should answer. Every answer has a line drawing that reminds the administrator what the behaviors are. So it allows you to match the video that you're looking at directly to the picture that you're seeing. If the child traveled 3 meters without stopping, then the app capitalizes on the iPad functionality to find the speed of their walk or their crawl based on the start and end times to go 3 meters. So they can just scroll back and forth until they find the exact start and end times. We have versions of the task for children with different skill levels, including babies who cannot yet crawl or walk, and for babies who can't even roll. The app guides the administrator to the appropriate version based on questions to the parent, and then it guides them through identifying and timing the skills that the child displayed. Reach to Eat assesses manual skills and tool use. This is an older child doing the Reach to Eat task. Older children reach for small Cheerios on a small base. It's just an upside-down measuring cup. And then they do the tool use task with a spoon. So first you'll see the easy version where the child just picks up the spoon. And then now you're seeing the more challenging version where the spoon handle is pointing the wrong way for that hand. Here's where the video playback really shines. Like, which of these 3 grips did that child use to grasp the Cheerio? It was really fast and really small, right? So the administrators can use the video playback to score important and really precise behaviors like grips. Using the video playback, the administrator can slow down, back up, and freeze the frame on the exact moment of the grasp. And Reach to Eat is adaptive. So all the tasks actually are adaptive. So this baby can't quite grasp a Cheerio from the small base. She knocked it off to the table. So instead of moving to the more advanced tool use task, the app prompts the administrator to test grasping with the large base. And now that child can grasp just fine. And for the youngest children who are not yet eating solid foods like Cheerios, they do a similar task with a block. Sit and stand measure stationary postural control. As always, there's a difficult component for each task for each age group, so they're never at ceiling. So this older child is trying to do a tandem stand with one foot in front of the other. This is really difficult. So even for this older child, it's still a challenge. Using the app, we can go back and forth to find the exact start and stop time that will reveal how long the child held the posture. So they drag through the video to find the moment that the child stepped out of the stand. For younger children, we assess basic sitting and standing. So here's an infant attempting to do a feet apart stand. Can't quite hold it for very long. And here's a baby doing the independent sitting task. Which postures you test are dictated by questions to the parents, and then the app guides you through what to administer and how to code it. And finally, for the youngest babies who can't even sit, we test head control. So that's called pull to sit. We're still in the process of developing the final scores. So far, we've analyzed about 2/3 of the data. We're going to have gross and fine motor composite scores and scores for subdomains that include postural transitions, locomotion, manual dexterity, and manual planning. We'll have full scores for get up and go and Reach to Eat, but for sit and stand, there were issues in administration and children's compliance, so we're recommending that sit and stand is used as a supplemental measure. In general, we're seeing strong correlations with age and nice variability within each age group. So here I'm showing you the correlation between the gross motor composite score and children's age. Although only a small subset of children return to complete the Bailey scales, we also find strong correlations between the gross motor composite score and the gross motor on the Bailey. Similarly, the Baby Toolbox fine motor composite score is well correlated with children's age, and the fine motor composite score is correlated with fine motor on the Bailey. In summary, for the NIH Baby Toolbox, we developed a way for non-experts to obtain detailed quantitative assessments of infant and child motor skills based on directly observed behaviors in a short amount of time. In like 10 minutes, you could measure a suite of manual, postural, and locomotor skills. And all of these tasks are based on functional behaviors with implications for daily life. Each task is adaptive, so that means from the very first clumsy movement in a 1-month-old to skilled, efficient, well-planned movements in 4-year-olds. And as you might have noticed from the videos that I showed you, the task can be administered outside of the lab setting because the only tools that you need are the iPad and a few common objects like measuring cups and a spoon. The big innovation is our use of the iPad's video capabilities to facilitate coding during the session. Precise video playback and side-by-side comparisons to drawings of the target behaviors allow for quick and accurate coding of even fine details of motor behavior. And the videos can be exported to be analyzed further. They can be shared on Databrary, they can be reused, they can be shown to clinicians if parents are concerned. And I want to acknowledge all the researchers and wonderful staff at Northwestern and at NYU who helped us to put this together, and the babies who let us try out all our crazy ideas during COVID, when we were trying to do it all on Zoom. So.
So, thank you very much, all of our speakers, for this session. Wonderful session. I will say that it was a nice blend, in my opinion, of the test developers and their analysis of the test to this point, as well as early adopters and scientists who so obviously we were doing a lot of the initial development of the test during COVID, and so not wanting to expose young children and infants, we had scientists, thank God a lot of postdocs had kids, so we had samples for all of the measures to develop the measures. That's not an inconsequential thing. Measurement development is a very detailed and lengthy effort. And I think it's important to recognize all of the work that everyone that's sitting up here today has put into making this a reality, a usable tool for scientists everywhere. I also want to acknowledge that all of the presentations were working with data before we have finalized the norming scores for the measures. Speaking about the normative values for each of the assessments that you've heard about today is difficult because that process also is a lengthy and very involved process of developing those norm scores. So we are moving quickly forward, but there is still quite a bit of work to be done before we're ready to release the tool to the public. The other thing I want to mention, aside from all of the work that was done during COVID, which was, I think, absolutely incredible work despite the challenges of COVID, is that we essentially have a large sample. We have validated it, and we have done some reliability testing as well. And you'll hear all of that once all of the scoring is done. So that wasn't reported today in part because that's still being analyzed right now. Important part of making a useful tool. And then finally, I would say the use of, one of the goals of developing the Baby Toolbox, the NIH Baby Toolbox, was to make it easy to administer, highly mobile, and not requiring the same number of boxes of peripherals that some of the other unmentioned measures that are already out there are. One of the challenges is to keep the number of items limited and to keep the time required to administer the test limited and the expertise to administer the test. So all of those things were unique contributions that the Baby Toolbox offers. In that process, though, a lot of people would say, well, can anybody off the street just start administering these tests? And the answer is no. And the no is for several reasons. One is it's a Class B measure, which means that you have to demonstrate that there is a scientific research or clinical reason why you want to administer the test, because when you make a test widely available to the general public, you have a lot of people practicing so that they score well. Obviously, hard to do with an infant, but even with an infant, you can bias the values. The other reason that we don't do just anybody on the street can administer the test, but we don't require an advanced degree, is that essentially it's really useful, as we saw for some of the video, thank you, Karen, that having some experience with young children and being able to manage their behavior in a test environment is very helpful. Then finally, the other item that I want to mention in regard to the measurement tools is that essentially we need people who can demonstrate that they administer the test correctly or effectively. And in doing that, the Northwestern team has consistently, both with the NIH Toolbox and with the NIH Baby Toolbox, we've used the train the trainer model. So that means the effort for the Northwestern team is lower, but we will facilitate, or they will facilitate, making sure that those folks that you train to administer the test are in fact prepared to administer the test correctly. All of those pieces are critical to measurement development and making an effective, useful, and reliable measure. So I was delighted that we saw on all of the slides that provided data that we have a high degree of validity, at least. We also have data that there's a high degree of reliability. So with that, I would like to open up the time to questions. But before I do that, I just want to mention that if you aren't able to get your question answered right now, you will have several other opportunities. There's an Ask the Expert session this afternoon as well as tomorrow morning, so that you can ask questions. And for those of you who are online, you can send your questions to the NIH Measures Conference. So it's NIH MEASURES CONF @mail.nih.gov. I'll say that one more time for the people who are online. NIH MEASURES CONF, at mail.nih.gov. So with that, we will open it up for questions.
Hi, thanks all of you. That was really great to see what's happening with Baby Toolbox. I was wondering if anyone could speak about the Mullen components of the Baby Toolbox and how that's going.
Thanks. So in terms of Mullen, currently we are working on developing scoring models for Mullen receptive and Mullen expressive. We just received the complete data set, so we can also score the Mullen visual receptive measure as well. But scoring is still in progress for all three measures, so results soon to come.
Hi, my name is Vidhu Thakur. I'm a pediatrician, physician scientist from Columbia, and I'm really here to see if I can utilize this resource for my research. So listening to HBCD study, that was very insightful to think of how to plan for it. And the question that comes to my mind is, what is the long-term plan of maintaining the trainability for these measures? As you mentioned, it's not something we can give to research assistants or research coordinators who are probably going to be college graduates or just fresh out of college, and we really need to be able to use the data correctly, we need to have validity and standardized, etc. So is there a plan, long-term plan, when the development part is done? Is there a plan by NIH, Northwestern, anybody else?
So I don't know if any of you want to answer that question. I have some answer, but go ahead.
I'll only just mention, as someone on the training team, that we are thinking about these things throughout the course of creating training materials and then disseminating them as well.
So there's a lot of effort that's going into developing training materials, including video, paper, the like. Northwestern shouldn't be the permanent certifier, but they will probably develop some system for certifying if you want. But that would not be offering everybody on your team throughout time training. Again, we would expect the train-the-trainer kind of model. Excuse me. And the goal is that the input from Northwestern for once the tool is released to the public is that there will be diminishing over time, but not nothing, sort of training efforts. But we are developing all sorts of tools to provide training that people can do in advance on their own. Erin?
So two things. One is I have done, I don't even know what it is, 35 sites of data collection, 48 sites of data video annotation for the NIH Play project. And I think it's very important to ensure that you have fidelity to the protocol, all the way through. If it were my study, I would want that. The motor measures, everything's on video. So it's really easy for you to determine your own quality assurance criteria and check periodically whether your people are meeting it or not. And for the other measures, it's also pretty easy to just put a video camera on what's happening. And that is, I think, the surest way to know that you have fidelity to the protocol, because you're looking at the data you collected, the raw data before it turned into a score, and then you can decide for yourself based on your quality assurance criteria.
I'll just add that for HBCD, we are training individuals who are most of them are post-bacs and have no experience with infant assessment. I would say there's variability. You know, you're always going to find that. You need the right person with the right personality is going to do a better job than maybe someone who's not as versed and comfortable with dealing with babies. So there's some element of that. But we certainly have been able to put people through those training experiences, and it's a relatively short 4 hours total for the initial training and then access to the materials. And they've been able to submit a video and been able to be compliant and reach the criteria that were established by Northwestern that we were taught to be able to get reliability. And then we're adding in that peer mentoring model so that we can maintain, we want that to be actually part of their active learning process. So they're looking at someone else's video while their video is being looked at, and then we're kind of monitoring that process over the course of time to make sure that we're adhering to good fidelity for what we're doing in the field, because we know in any of these studies drift occurs. So it depends on what you want or how you want to orchestrate it, but I think it's a great model for how to make sure you have good assessments done from the beginning and to the end of your study. So.
Thank you. So we are actually past 2 o'clock, and so we need to stop. We hope that those who had questions that were queuing up will come to the Ask the Experts. So thank you very much, everyone. Very glad to have you here today.
All right. Hi, folks. We're going to get started. My name is Matt Sutterer. I'm a program officer at the National Institute on Aging, and I'm going to be moderating this session, NIH Toolbox Across the Lifespan and in Clinical Populations. And the first speaker is Callie Tyner from the University of Delaware with the title New NIH TB Visual Reasoning Test. So come on up.
Okay, hello. Hopefully you guys can hear me. This is okay? Great. Oh, speak louder? Okay, great. I'll work on that. And then advancing. There we go. Okay, so I'm Callie Tyner, and I'm here from the University of Delaware, and I'm excited to be sharing with you some information on a new test for the toolbox that I helped to develop as part of a team called the Visual Reasoning Test, or VR. I'm going to describe the impetus for the new test, the approach we use for developing it, and some information on its psychometric properties. So why did we develop a new test for the NIH Toolbox? Aren't there enough tests already? No. There's a large study, the ECHO study that you may have heard of, that uses the toolbox. And early in this project, the stakeholders were asked for feedback. And we looked at that feedback and realized that a test of abstract visual reasoning was something that was missing from the current tests available for children. So you may be aware visual reasoning tests are good measures of visual abstract reasoning, and they generally are highly correlated with general cognitive ability. So it could provide a nice balance for the tests in the NIH Toolbox that are the other verbal tests like list sorting, working memory, and other things like picture vocabulary that are verbal. It's also we thought it could be helpful for children, especially younger kids who don't have the skills of reading or writing ability, to be able to evaluate them in kind of a non-verbal way. And we actually wanted to see if we could develop a test that would work for children as young as 3. So what was our development approach? A major factor that we considered a lot was timing. Since we're adding a test to the toolbox, we didn't want to increase the time burden of the test by adding this lengthy test too much. So our goal was a test that would take maybe 5 to 7 minutes to complete. Generally, we tried to follow the design principles of the NIH Toolbox so that it would be free of intellectual property concerns, able to be administered on the iPad with multiple choice responding, and require limited examiner involvement. We also had a goal for lifespan assessment, so we wanted it to be approachable for kids of preschool age and older. And we also wanted it to be sensitive to cognitive deficits, of course, and we wanted it, because of that, we wanted it to be free of potential confounds that might interfere. So let me review a few of the challenges we faced when developing this. One thing that we thought about often was timing. We wanted to keep it brief to avoid increasing the burden. And if you have given a test of visual reasoning before, you may be aware that these can be pretty time intensive. They often take 10 minutes or sometimes more like 20 or 30 minutes, depending on the individual. So we thought about this a lot. And it may seem on the surface like imposing a time limit would be a natural answer to keep it brief, but we were actually very strongly opposed to this because we didn't want to impose working memory or processing speed requirements to complete the test. So instead of a time limit, we actually worked to develop the test as a computerized adaptive test as a way to balance brevity with the goals of high reliability. Another major challenge that we considered was the fact that this was going to be a visual test and ideally more of a nonverbal test. So we wanted the test to be free or independent from verbal skills like reading, speech, listening, semantic knowledge, verbal reasoning, things like that. So our approach to resolve this challenge was focusing both on how we taught the test and how people would respond to the test. So for teaching the test, we actually developed animations that are shown in the app when someone is learning how to do the test. Their animations are played while they hear the instructions that are pre-recorded, and the instructions are also written on the screen. So while I'm hesitant to call it a purely nonverbal test, because there are still instructions that are verbal, I think adding the animations really lowers the verbal demands of the test and makes it a little more nonverbal. Also, for responding, participants just tap an image on the screen, so there's no need to name the item that they see or give any kind of spoken response. The third challenge that we faced that was really important for this test was the fact that there are a lot of common sensory visual problems that could interfere with performance on a visual test that we didn't want to interfere. So things like color perception or color blindness, visual acuity, these all vary and appear pretty frequently in the neural population. And so we worked to avoid them by having avoiding fine details being critical for responding, difficult to perceive differences in shading that might require high levels of contrast sensitivity, and also we worked to avoid challenging color combinations like red-green or blue-purple we didn't want those to be critical to getting the right answer. So with all these considerations, we developed 204 items. The skills assessed included stimulus discrimination, pattern completion, analogic reasoning, serial reasoning, spatial visualization, and mental rotation were all the different kind of cognitive skills involved in the items. On the screen, I have a few example items. These are not real items. And they seem very easy because these are examples of some of the easiest types of items we develop for young children. The two on the top are the pattern completion kind of items, and the bottom left would be a serial reasoning type of item, and the bottom right is an analogic reasoning type of item. So we next moved these items into several phases of testing. We first conducted an item tryout and then 2 pilots. Our goals were first to identify concerns with any of the items, things like items that were confusing, or they took too long for people to respond, or where participants devised a plausible answer other than our intended correct response. We also did these tryouts and pilots to gauge the feasibility, particularly the feasibility for younger kids responding to this test, and also the time required for adults to take it. Those were the things that were on our mind. So first we did an item tryout with 95 people in person, and 23 people after that took a post-test cognitive debriefing interview where we used that to detect any unintentional challenges or problems with the items. And then we next completed 2 pre-calibration pilots. One was in person and another was with an online research panel. Based on the item tryouts and the pilots, we did remove, modify, and actually developed a few new items to fill some measurement gaps. We learned from these results that children were able to complete the test successfully, and we did find, though, that children younger than 5 struggled with the more complex item types, except for the simple comparison type of item, an example of which is on the screen. So regarding timing, children responded faster than adults. And for adults, we found that slower responding was actually associated with better performance, which reinforced what we knew about visual reasoning tests, where they can be quite lengthy. So next, we prepared the items for a norming and calibration study. Visual reasoning was included in the NIH Toolbox V3 norming study, and the data from that were used to calibrate the items and develop norms. The study included an assessment of test-retest reliability, as well as an assessment of convergent validity, using the matrix reasoning test from the Wagster intelligence scales as a gold standard measure of the construct. Calibration analyses resulted in a bank of 180 items. Based on extensive analysis of the calibration data set, it was decided to norm the test for ages 4 and up, and we were able to calibrate the test as a cat. Based on simulations from the norming study, it'll take between 2 to 5 minutes for children to complete the cat and 4 to 9 minutes for adults, with most adults completing the test in less than 7 minutes. Test-retest reliability was also good and consistent with other NIH Toolbox fluid cognition tests. This is a graph of a plot of the scores on VR by age, and we found that for 3 to 11-year-olds, age was moderately to strongly correlated with VR scores in the positive direction. The association with age was smaller for ages 12 to 17, suggesting that that's the age range where the construct starts to stabilize. And for adults, VR scores were negatively correlated with age, which is consistent with other fluid cognitive tests that peak around age 25 and slowly decline with age. Looking at the associations with the validation measures, the Wechsler matrix reasoning tests, convergent validity was supported for VR. We hypothesized a correlation of 0.5 or greater, which was used when developing other NIH Toolbox cognitive tests. And that was generally found for this study for children over 6 on the WISC and adults on the WACE, although it was slightly weaker for children ages 3 to 5 who took the WIPC. We also consider the associations of VR with more general measures of cognitive functioning, specifically the Wechsler full-scale IQ or FSIQ and the NIH Toolbox cognitive composites. As you can see, VR appears to be a strong proxy for general intelligence and cognition, which has been observed with other similar tests. And this was especially true for school-age children, where the correlation of VR with full-scale IQ was nearly identical to the correlation of full-scale IQ with the NIH Toolbox total cognition composite. These results also supported considering VR as a fluid cognitive test for adults, where it was more strongly correlated than with the crystallized cognition, although this distinction wasn't present for children, which is consistent with what we know about the trajectories of fluid and crystallized cognition that are similar, developmentally similar for children until later teen years. So in summary, visual reasoning was developed de novo and can be given as a cat. It's released now in V3, the iPad app for the NIH Toolbox. It expands the coverage of the Toolbox cognition domain to be more inclusive of visual spatial reasoning skills. And we've seen moderate to strong correlations with matrix reasoning, full-scale IQ, and Toolbox cognition composite. We think that perhaps we'd like to study with more research that VR could perhaps be combined with the picture vocabulary to form a 2-subtest IQ estimate, and this is something that we're going to look at further. So please check out the Toolbox website or reach out by email if you would like to ask any questions. Thanks.
Thanks, Callie. Next speaker is going to be Gail Hermata from the University of Iowa, whose talk is titled Associations Between NIH Toolbox Emotional Battery Measures and Previous Suicide Attempt in Bipolar Disorder Type 1.
All right. let's get started. So, unfortunately, bipolar disorder is a severe psychiatric illness characterized by mood swings, which include depression and mania. So there are two subtypes that kind of have different profiles of how those mood swings look like. So we have type 1, which is characterized by at least one full manic episode, and type 2, which is more focused on depressive symptoms, and hypomania, so not quite as severe of mania symptoms. For the purpose of today's talk, our sample included people with type 1. Individuals with bipolar disorder are 30 to 60 times more likely to attempt suicide than the general population in a given year. And over their lifetimes, up to 50% of affected individuals will attempt suicide, and up to 20% will die by suicide. Therefore, a better understanding of risk factors may help us to predict and prevent suicide attempts in this population. There are many risk factors that have already been identified for suicidal behavior in bipolar disorder. One of the biggest ones is past suicide attempt is predictive of future suicide attempt. A family history of attempt or of mood disorders is predictive of future attempt, and several SNPs have been associated with suicidal behavior. Having an alcohol or substance use disorder, gender, which is actually kind of interesting in that females are more likely to, or women are more likely to attempt suicide, but men are more likely to die by suicide. Possibly, in part explained by the lethal method used, or the lethality of the method, but not necessarily completely, which is another question. But continuing on, other sociodemographic factors might include family structure, socioeconomic status, past history of abuse. We have a variety of different constructs and experiences that are contributing to risk for suicidal behavior. There are also different psychosocial and emotional factors, so things like sadness, perceived quality of life, hopelessness, various these kinds of dimensions of the emotional experience. And then also the characteristic of an individual's psychiatric symptom profile, where a person with severe depressive episodes or a current depressive episode, also people with more rapid cycling, and earlier age of onset and delay of initial treatment are all factors that contribute to a greater risk for suicidal behavior. So a big question here is, can we better understand how some of these social and emotional functioning constructs relate to suicide attempts in bipolar disorder? Now, what we decided to do is we chose the NIH Toolbox as a way of looking at this that was had several advantages. We've already discussed this throughout the day, how it's a single and brief assessment, and it for all the constructs that it covers. We zoomed in on the emotion toolbox, the motion battery. So this battery covers a variety of constructs, and which we'll go over in a bit. It's well validated, and it's self-administered, and that it does not require a clinical interview. So some of the assays that we collected in our cohort were clinician or experimenter delivered, whereas this one was self-administered. Now, in terms of how this has been used previously in suicide research, the NIH Toolbox has been employed in at least 2 studies related to suicidal ideation, but not, to my knowledge, in terms of attempt. And it's really important to distinguish these as concepts because the vast majority of people that have suicidal ideation do not go on to have an attempt. So that's another question that we might end up looking into, but for the purposes of today, we are looking at history of actual attempt. So we use version 2 of the toolbox, so it'll be a little bit different from what was described in the earlier talk today in terms of the emotion subdomains. So in domain 1, we have psychological well-being, positive affect, life satisfaction, meaning and purpose in life are the subdomains for that category. For the social relationships domain, we have emotional support, instrumental support, friendship, loneliness, perceived rejection, and perceived hostility. In domain 3, we have stress and self-efficacy, which are stress and self-efficacy. And in domain 4, we have negative affect, so we have fear, affect and somatic arousal aspects, sadness, and 3 different types of anger aspects, including affect, hostility, and physical aggression. So the primary purpose of the study was actually to collect MRI results on the brains of individuals with bipolar disorder type 1, but we collected a variety of information from them, including NIH Toolbox measures. So we recruited people with and without bipolar disorder type 1 for this imaging study, and diagnosis was confirmed with the SCID-5 diagnostic interview. And its assessments included the Montgomery-Åsberg Depression Rating Scale, the Young Mania Rating Scale, the Beck Anxiety Inventory, and the Columbia Suicide Severity Rating Scale. And of this study, we started the study and we decided to add the NIH Toolbox in. So of our total study, 148 of the participants completed the emotion battery component of the toolbox. So here's a truncated version of our demographics and clinical results table. You can see that we have here on the columns controls bipolar disorder type 1 without an attempt history and bipolar disorder type 1 with an attempt history. We didn't have a difference in sex distribution or age distribution, but it was notable that, that's a little off there, it was notable that the self-reported socioeconomic status, the adverse childhood event score, the depression, which is MADRS, mania, which is the Weimers, and BII, which is the anxiety indicator, were all different between the 2 groups of bipolar disorder participants. So we can't rule out, for example, that there were some sort of socioeconomic differences between the groups here, but we thought it was interesting to note this. So our first question was, does the emotion battery correlate with any of the clinical symptom scales that we collected? And we saw some pretty believable results. So we saw that, for example, here we can see this is a heat map. On the bottom, we have the correlation rating. This is Spearman's row, correlation coefficient. And then we have on the rows, we have the clinical assessment scales. And then we have each of the different subdomains of the emotion battery in the columns. And you can see that some of the things you would expect to be more adaptive are usually negatively correlated with some of these symptom rating scales, and things that might be more adaptive are, or instead of that backwards, things that are you would want to be adaptive are negatively correlated. Things that are less adaptive are positively correlated. So, for example, one would expect sadness from the toolbox to be highly correlated with the depression score, and indeed we see that. So that is really reassuring that we are capturing clinically relevant information with the toolbox. And we also have a more detailed breakdown of this by questions on each of the assessments, but for the purposes of time, we're not going to go into that. Our primary question was, does prior suicide attempt history in bipolar disorder type 1 relate to responses on the battery? And in order to avoid you having to look at 17 different graphs, I just kind of summarize this on this slide that indeed we see numerous domains are different between the 2 groups of bipolar disorder participants. So we see here in blue that we have the individuals that do have a prior suicide attempt have lower reported rankings on these items. So we have life satisfaction, emotional support, instrumental support, friendship, and self-efficacy are lower in this group, whereas loneliness, perceived rejection, stress, sadness, anger, hostility, and anger, physical aggression are higher in this group. We also observed some differences between controls and the other 2 bipolar disorder groups, which are marked with asterisks, but I highlighted the ones that were different between the bipolar disorder groups because they were our primary target of interest. So all of this makes sense, but then we were also interested in, can we combine all of this information together to identify which group an individual belonged into based on these measures alone? So, and if we can, which measures are the most important in that classification? So we developed a machine learning model. We selected a random forest to allow for inherent variable selection and potential interactions between variables. We used 5-fold nested cross-validation. And this was really important, especially because of our relatively small data set. We wanted to improve rigor and reproducibility. The 19 features that were included in the model were the 17 subdomain ratings, as we had seen in that graphic before, and age and self-reported sex. And the outcome was binary, so we removed the control group from this, and we looked only at within bipolar disorder participants. And then variable importance was computed via the mean decrease in accuracy of the model when the variable was permuted. And you can see the results here that overall the model was able to predict group membership with around 70% accuracy. And in this graph here, we have mean decrease in accuracy with permutation. So that means that when you have a bigger number, that means that the accuracy of the model was hurt the most when that variable was permuted. So you can see that the most important variable then is emotional support at the top when these are in descending order. Then we have anger, hostility, perceived stress, anger, physical aggression, self-efficacy, and perceived rejection. And then again, we have these color-coded to indicate the directionality of the effect. And again, this corresponds with the previous slide. This all makes sense in ways you would expect, such as like loneliness being higher and all that. But the emotional support was definitely the one that was in the lead here. So just to kind of wrap this up, we definitely observed that mood and emotional constructs are being captured in ways that we would expect by the toolbox. And this was related to suicide attempt history within bipolar disorder participants. The machine learning model that we used had moderate accuracy and identified the top distinguishing features, and we believe that by identifying these top features, we can potentially guide future treatment or intervention options. So, for example, if there were more policies to increase the availability of emotional support, so maybe therapies or promote some other sort of like intervention that providing people access to someone to talk to, also stress reduction and management methods, all of these things could lead to different changes in treatment, and they warrant further study. It is possible that the battery could have clinical utility as a screening tool for future suicide attempt risk, but again, this was a cross-sectional study, so we would need to have further longitudinal studies to assess this. And we are hoping to combine our current work in the MRI imaging with this work and report on those results in the future. Thank you very much.
So next up, we have Leila Gakete-Laze. Am I close? Okay. From the University of Maryland with the title Cognitive NIH Toolbox Assessment in Patients with Drug-Resistant Temporal Lobe Epilepsy versus Controls.
Good afternoon. I'm Leila Gakete-Laze. I'm an epilepsy fellow at the University of Maryland, and I'm happy to be here today to talk to you about the NIH Toolbox cognitive assessment in patients with drug-resistant temporal lobe epilepsy versus controls. The authors have no financial disclosures, and to give a better understanding of the origin of this project, before we dive into the details, let me set the stage by sharing the background story of this project. So the primary way to measure cognitive functioning in patients with drug-resistant temporal lobe epilepsy is through the comprehensive neuropsychological assessment, which is considered to be a gold standard test. So this comprehensive neuropsychological assessment has many advantages, such as it provides detailed information regarding performance in a variety of cognitive domains, and this information provided assists in surgical planning and prediction of post-surgical cognitive outcomes in this patient population. So while the neuropsychological testing yields rich information for clinical as well as research purposes, there are several challenges when using these measures, such as it needs to be administered by a highly trained examiner and interpreted by a clinical neuropsychologist. It's a pretty expensive test which limits access, and also it consists of lengthy battery of tests that requires time to administer as well as score. So with that in mind, let's talk about the NIH Toolbox. Cognition is one of 4 domains measured by the NIH Toolbox for the assessment of neurological and behavioral function. And the NIH Toolbox Cognition Battery was developed to assess key components of cognition. It's a quick iPad-based assessment tool, and it's also a cost-effective method to execute and trend over time. So the NIH Toolbox measures have been widely used and validated among individuals with various clinical conditions, but to our knowledge, no studies have been published in patients with drug-resistant epilepsy. So when we do cognitive assessment in patients with epilepsy, we know that they're going to score worse than controls. And building on that idea, in the study, we aim to demonstrate that the NIH Toolbox Cognitive Battery is sensitive enough to identify cognitive differences between patients with drug-resistant temporal lobe epilepsy versus controls. So now let's turn our attention to how we designed the study. So the patients with temporal lobe epilepsy at our level 4 epilepsy center were screened, and this is the inclusion criteria that we used. Patients with age more than 18, confirmed temporal lobe epilepsy by continuous video EEG monitoring, drug-resistant epilepsy undergoing pre-surgical workup were included in the study. So drug-resistant means that all patients continue to have seizures despite having had trials of 2 or more anti-seizure medications at therapeutic doses. Patients with prior intracranial surgery, history of uncontrolled mood disorder, and inability to obtain consent were excluded from the study. So we matched healthy control subjects based on age and gender, and then we collected this de-identified patient information, including age, race, gender, epilepsy, duration of epilepsy, and then they all underwent NIH Toolbox Cognition Battery testing. So once they underwent the testing, we used a fully corrected T-score from each test for comparison, and we analyzed the data by using unpaired t-test. So why we used fully corrected T-score, we will cover that in more detail later on. So moving forward, let's delve into the characteristics of the participants at baseline. So we had total 33 subjects that we recruited, and from this 33, 15 were temporal lobe epilepsy patients with mean age of 41, and we had 18 controls with mean age of 38. From temporal lobe epilepsy group, we had 7 with dominant temporal lobe epilepsy, dominance meaning language dominance. We had 6 with non-dominant temporal lobe epilepsy and 2 with bitemporal epilepsy. So the main notable difference between the TLE and control group was in race and education. So in temporal lobe epilepsy patients, we had almost equal number of white and black population, while in controls, majority of patients were white. Education-wise, in temporal lobe epilepsy patients, most of the patients had high school or college degree, while in controls, majority of patients had masters and beyond. Considering this difference in race and education, this prompted us to use fully corrected T-score instead of age-corrected T-score, as fully corrected T-score is adjusted based on age, gender, education, as well as race. Now that we have covered the baseline characteristics of the study subjects, let's discuss the results. So these are the domains assessed by the NIH Toolbox Cognitive Battery, and these are the measures used to assess those domains. So we have 2 measures from NIH Toolbox for attention and executive function. We have 2 measures for language, and the other 3 domains have 1 corresponding measure from NIH Toolbox. So in most cognitive domains, these are the T-scores, mean T-scores in temporal lobe epilepsy group and mean T-score in controls, and this is the p-values. So in most cognitive domains assessed by the NIH Toolbox Cognition Battery, being attention and executive function, working memory, and processing speed, Control group scored significantly higher than the temporal lobe epilepsy group with a p-value less than 0.05 as we expected. There was also a trend towards significance in language domain based on the oral reading recognition test, but there was no difference based on picture vocabulary test, and we didn't see any difference in episodic memory. Now let's shift our focus to the limitations of the study. So the first, the sample size is pretty small, and this might be the reason why we didn't see statistical significance difference in episodic memory and language, as we had to combine all epilepsy patients together, including dominant as well as non-dominant temporal lobe epilepsy patients. Battery is relatively brief, and we also had notable difference in race and education in epilepsy cohort versus controls, but to overcome that, we used fully corrected T-score. So to bring the presentation to the close, we identified that the control participants performed significantly better than the temporal lobe epilepsy patient across multiple cognitive domains, including attention, working memory, processing speed, and executive function. And our results suggest that the NIH Toolbox cognitive battery can be used as an adjunct test in patients with drug-resistant temporal lobe epilepsy. So we feel that it will be a particularly useful assessment tool to assess cognitive trends over time in this population, especially if the patient is undergoing surgery or neurostimulation down the road. So moving forward, we're working on having a bigger sample to be able to classify patients based on their epilepsy diagnosis, and we're also looking into comparing NIH Toolbox with neuropsych assessment and see if the scores correlate. Thank you.
Thank you. So our last speaker actually is Ferouz Orguz, who is actually going to be joining us remotely from the Sapienza University of Rome. And her title is Individual Psychological Traits Predict the Activity of Limbic and Prefrontal Areas. Ferouz, can you hear us?
Yes. Is my voice clear?
We hear you loud and clear.
Okay, perfect. Hello, everyone. First of all, thank you for having me today. I'm really happy to be a part of this organization. I'm Ferouz, and I'm postgraduate master's student in neuroscience field. And today I'm going to talk about my project on individual psychological traits predict the activity of limbic and prefrontal areas. Next, please. We can go a bit next because there are a lot of animation. Yes, go, yes. One more, yes. So I would like to start with emotion recognition, which is one of the most appealing and well-known topic in the psychology when it comes to diversion of the emotion processing. Researchers, when they investigate this topic, researchers mostly use facial expressions of basic emotions, which we all know as happy, surprise, angry, fear, disgust. And they use facial expressions because it's proved that motivationally relevant stimuli evokes a response even though there is no existing emotional contact. And as negative emotions, anger and fear is very well known with evoked limbic area activation in the neuroscience field. However, limbic system is also known as their involvement in cognitive traits such as fluid intelligence, executive functions, and spatial orientation, and so. This is also can be considered for emotional traits for cognitive areas. Characterizing these unconventional relations and individual differences for cognition and emotion is one of the most challenging topics in the neuroscience field nowadays. Next, please. To investigate this, we would like to point out the relations for cognitive and emotional traits during the emotion processing and working memory fMRI task. And we basically expect the variation of limbic and prefrontal areas variation actuation that correspond to our emotional and cognitive factors as behavioral factors. Next, please. The question is, how did we investigate? To make this study possible, we used Human Connectome project by Washington and Minnesota University, and we recruit 894 participants for both behavioral and fMRI data. For fMRI data, we had emotion processing task, which is basically a matching task for angry and fearful faces versus shapes. For working memory tasks, we had basic in-back tasks with 2-back and 0-back procedures with body, face, tool, and places. Next, please. For behavioral measures, NIH Toolbox took a really big role in our behavioral part, and for cognition, we used dimensional change card sorting and processing speed and flanker tasks. For the emotion, we use negative affect domain, referred as anger, hostility, physical aggression, fear, and somatic arousal. For additional measure, we use Pennsylvania University computerized neuropsychological task module, which is progressive matrices task and line orientation task for cognition, and emotion recognition task refers angry, fear, and neutral recognition. For all tasks, we use age-adjusted scale. Next, please. For the statistical analysis, first of all, we would like to simplify the data for further analysis. So we did exploratory factor analysis by their eigenvalues and aim of measures. At the end, we obtained fluid intelligence, spatial orientation, executive function for cognition, and for emotion, we had negative effects. Next. For fMRI analysis, first of all, we did first level analysis to define our contrast, and then we had our one sample t-test to observe our significant areas. Next. As you can see on the right image, we have our significant areas for the working memory task, and on the left image, we have our significant areas for emotion processing task. In the left, you can see emotion versus shapes contrast, and on the right, you can see 2-back versus 0-back contrast. To do our further analysis, we extract our regional data with ROI analysis, and we had our regions of interest. Next. Our regions of interest were amygdala, hippocampus, and thalamus for limbic area, dorsolateral and ventrolateral prefrontal cortex for cognitive areas, and we took also fusiform face area because it has the peak activation since we had face matching task. Next. And at the end, to observe the interaction, to observe our hypothesis results, we looked at our interaction between average activation of region of interest and behavioral factors. Next, please. To sum up, our multiple regression analyses were conducted to observe the interaction between region of interest, which were hypothalamus, amygdala, and hippocampus, and ventrolateral prefrontal lateral, prefrontal cortex, and fusiform face area versus behavioral factors, which are fluid intelligence, spatial orientation, executive function, and negative affect. Next. In results, derivative results, we observed that there were higher fluid intelligence scores associated with dorsolateral and ventrolateral prefrontal cortexes during fearful and working memory tasks. Next. And as a supportive evidence, we have our limbic area activations during the working memory and angry phases associated with spatial orientation behavior factor. Next, please. And again, as a supportive evidence, we had our dorsolateral and ventrolateral prefrontal cortex activations during during working memory, which is associated with executive function. Next. For the emotion factor in a negative effect, we had our right hippocampus and dorsolateral prefrontal cortex activations, but no significant relations were found during the emotion task. As sum up, we can see these results as a multidirectional research which can be interpreted as for clinical studies, for example, individual differences for behavioral factors and neuroscience, the limbic area and prefrontal area involvement, their importance during overriding for behavioral factors, and also it's a really innovative perspective to combine behavioral factors to brain imaging models to elevate our statistical analysis. And for limitation, I can say that we can cut most of the pre-acquired data limitations for this study. At future directions, we can use more sensitive psychophysiological measures such as heart rate variability. Measuring heart rate variability will be really helpful during the negative emotions, or this collaboration of prefrontal cortex activation and limbic area activation reminds me directly to functional connectivity studies, and it will be very helpful to elevate this project. Next, please. Thank you for listening. I will be waiting your questions.
Thank you. We are now at Q&A, so if I could get the other speakers to come up on stage, and if you can stay on the line.
Okay.
And if folks have questions, please come down to the microphone. And then for those of you listening online, if you happen to have questions, please do send them into the mailbox at NIH Measures Conf, conf@mail.nih.gov, and we will reply after the meeting.
Hi, everyone. Very nice talks. Thank you very much. I was interested in the one with intractable epilepsy, and I was wondering, you're using the NIH Toolbox for pre-surgery. Have you used it post-surgically, and what kind of results were you seeing? I can't hear you.
Tap the mic.
Can you hear me now?
Try it again.
Can you hear me now?
Oh, yes.
Yes. So this is like the first part of the study, and this is the data that we analyzed as of now, but we also collected the data in patients after RNS placement and after surgery. So our plan is to compare the data that we have, that trend to see after surgery as well as RNS. So we're working on that, but we don't have results as of now.
Perfect. It'd be really interesting to see if your scores have actually improved, and because they no longer have epilepsy anymore. Thank you very much.
We have a good amount of patients who are undergoing the RNS therapy. I mean, like neurostimulation, and we think that neurostimulation meaning that it provides, like, it stimulates your brain, and that kind of like helps to prevent seizures, and we think that might have a positive cognitive effect in this patient group. So we have decent amount of patients who have that RNS already in place, and they are undergoing NIH Toolbox testing every 6 months. So we're working on that data too.
Fabulous. Thank you.
Other questions? Otherwise, I'll take a moderator prerogative here. Yeah, I'm wondering if you could speak a little bit more just about your experience using the emotion battery for the toolbox. We haven't had, I think we've heard a lot about sort of the cognition battery, but your experiences using the emotion battery and ease of utility compared to some of the clinical assessments?
That's a great question. I will say that I am not the person who is administering it, so I don't want to overly interpret this, but my understanding is that it's been pretty simple to implement. I think there will occasionally will have people that ask questions about, well, how should I answer this? And they kind of waffle around about things. And that may also be related if they're in a manic state, to be a little more chatty about things. But overall, it's been a good experience. I think that in terms of length, the rest of the toolbox takes longer than this part, but we kind of prioritize the emotion battery just because of our cohort. But yeah, we are interested in implementing the rest of the toolbox as well.
Thank you. Other questions from the audience?
So this question's for Callie. Am I saying that right? Gotcha. So I was just wondering, in general, I know that your visual task, your reasoning task, had multiple different kinds of questions, like the analog or the serial. Was there any motivation for making that different from what the waste does, for example? Like there were two entirely different kind of question types with the, I think, the completion versions of it?
So I think you're talking about with the waste that you sort of explained that either you're looking at a grid of 4 or 9 and you're looking for something that's missing, or there's like a series of pictures and you have to detect the pattern. So we did use both of those kind of types. So either a grid of either 4 or 6 or 9 things with something missing. Sometimes we have items where more than one thing is missing. And then we also use the series, and we expanded it beyond that, beyond those 2 item types, to also include, I think I had an example of a simple comparison. So really for the youngest kids, that was the item type that was the most consistent that they could answer, was looking for the stimulus in one of the response choices as a very basic level. So I think your question, I want to make sure I'm answering your question, is that why we elaborated on that? Is that why you were asking?
Yeah, just why did you mix those together? Like the waste doesn't do that, for example, in terms of the third type, the last one you just spoke about.
Right. Well, a lot of it had to do with our interest in expanding the age range. So we were trying to develop items that would work for kids as young as 3, which is a hard age to develop complex items for, because you're talking about kids where even just the question answering process is challenging for them, sitting in front of the iPad, understanding that they need to pick a response. That's really challenging. So that was a big part of why we tried those out and they worked. There have been a lot of different kinds of visual reasoning tests. So I think the matrix reasoning from the Wagster is particularly popular right now. But there are a lot of other tests, like the Raven's progressive matrices that people have been using since the 30s. The TONY, the test of nonverbal intelligence. So there's a lot of different existing tests that get at this sort of visual abstract reasoning. And so we use the Wechsler version as kind of our gold standard because it is really well established and popular right now. But I think that when we conceptualized what the construct was that we were trying to measure, visual abstract reasoning, we wanted to try to be inclusive, particularly because it is going to be given as a CAT. We needed to have a good range of item difficulties to be able to measure people, whereas on something like the Wechsler versions, it's not a CAT, right? So they get a raw score based on how many items they complete. So with our test, we really needed them to be able to jump in with difficult items.
And just if you have time for a follow-up question, actually, I was also wondering, I think at the very beginning of your talk, you were talking about how you wanted to create a visual analog to some things that already exist in the toolbox. Mm-hmm. And I was just wondering, you even cited I think the list working memory task. Mm-hmm. was there any interest in doing a visual working memory task? And how did you end up on visual reasoning as opposed to like any other sort of analog domain?
Yes, so there are a number of visual, I would think, like speeded matching for kids is kind of processing speed, working memory for kids. I feel like the NIH Toolbox already has a lot of kind of working memory focused things like flanker. I always blank when I'm trying to think of other example tests. But just by nature of with cognitive assessment, I think it's easy to default to more verbal tests because that's a really helpful way to evaluate someone is to talk to them, give them instructions, have them provide a response. But so I think that was kind of what was missing with the toolbox that we were trying to fill in a gap was something a little bit more nonverbal. And I have an interest in evaluating the performance on the tests for people who maybe have a clinical condition that's leading them to be in a more nonverbal category, like an autism spectrum disorder. But we haven't done those analyses yet.
Thank you.
Yep.
Yeah, this one is also for Dr. Tyner. I'm a recent adopter of the toolbox clinically in the community, and I had occasion to work with a 68-year-old woman recently who was experiencing potential early dementia signs, decline, also with a lot of anxiety. And this is more of a clinical observation. I like progressive matrices, so I really like your test. But this one woman, her anxiety spiked through the ceiling when she took this test. And as somebody still new to administering the battery, I struggled on how much I was going to say to try to work to calm her down, to encourage her to keep trying because she would get frustrated and just make it, I'm just going to guess. So I don't really have a question as much as just this observation of the reaction this one individual had. So for what it's worth.
Thank you for sharing that. That's nice to hear it's being used in the field. Thank you.
I guess to try and formulate that to sort of extrapolate into a question in terms of your experiences sort of developing these tests. Did you encounter sort of, I don't know, in terms of user acceptance training or, sort of other aspects, sort of experiences similar or distinct from that you maybe had to sort of filter in?
Yeah, I think that one of the areas that came to mind was, I alluded to this, I think, a few times in my presentation, that we did have to really balance the pressure of the test not adding a significant time burden to the toolbox, despite the fact that it can take a long time for people to do, right? Visual reasoning tasks. From my own clinical experience, I know I've taken 30 minutes with some people to finish matrix reasoning, particularly if they're high functioning, particularly if they have perhaps anxiety about picking the wrong answer, and really wanting to check and recheck their work before giving a response. So that pressure exists. And then on the other hand, we wanted to really keep the test brief. So the CAT was the solution that we came to. But I have wondered if, because the CAT will start, it starts with different items depending on the person's age and education. I have wondered if it's missing perhaps kind of the buildup that you get from a non-CAT test where the first dozen items are very easy and sort of maybe help someone build confidence with the test. So that's probably something we should consider and look at a little bit more. But it's just, I think, the nature of needing to manage the time constraints by kind of removing that build-up period and bringing someone into the CAT environment where perhaps if they get their first item right, then they're given more and more difficult items very quickly. So thank you for the question and the observation.
Quick one. Does it have an adaptive design? Like, are you torturing people over 7 minutes, or does it end?
Yes, so it does end. It is a computer adaptive test, and so I think it caps I think it's 20 to 35 items. So it would end at 35 items or after a certain standard error is reached after a minimum of 20 items. So again, it's not going to torture people and force them to do all of the items, but it will, it gives a number of items. And I think for adults, most people were done in 7 minutes. But a few people took up to 9 in the simulation. So.
All right. Well, we are at about at time here, and I don't want to keep those of you in the audience from going out and seeing the partial eclipse that we get here in Bethesda. I just want to thank all of our speakers and let folks know in person that the poster session and Ask the Expert session will begin at 3:45 in the atrium, as well as balconies A and B. For the online audience, this is the end of our virtual content for the day. We will be resuming the conference videocast tomorrow, April 9th at 11:15 a.m. That is a separate link than the one you watched today. But you should have those details at home. And thank everyone.